Good morning and welcome everyone to our 8th annual Young-Onset and Hereditary Colorectal Cancer Education Day. Thank you all for joining. While this is the 8th edition of our Education Day, there are some new things about today's event. Firstly, this is our initial attempt at doing this virtually, and I'm hoping in terms of technical issues, nobody is having major problems and logging on. So secondly, another major difference to this year's event is that besides focused on hereditary colorectal conditions, we have broadened the topic to include young-onset colorectal cancer. And this is in parallel to us recently having formed a new center here at the Cleveland Clinic that is dedicated to young-onset colorectal cancer. As many of you know, there's an alarming increase in young-onset colorectal cancer, not only here in the US, but also around the world. And the goal of our center is to focus on addressing the concerns that are particularly to colorectal cancer in the young, but also advance the field through research and education so we can learn why this is happening at a higher frequency and what we can do to reverse this trend. And a lot of it will be through events such as these to raise awareness and understand more why this is happening. Now, since patients with hereditary colorectal conditions share many of the clinical concerns that also need to be paid attention to in young onset colorectal cancer, we thought it would make sense to combine these two topics in the agenda for today. So most of the topics that we'll be talking about today are fairly broad and should be of interest to patients and family members with hereditary or young onset colorectal cancers. So without much further ado, I first want to thank my course co-directors, Dr. Carol Burke and Brandie Leach. Both of them don't need much introduction. Most of our patients know both of them very well. Dr. Burke has been here at the clinic, I think, now for almost 30 years, one of the biggest experts in the world on hereditary gastrointestinal cancer conditions. Brandie, similarly, is one of the biggest experts in genetics of cancer, and especially colorectal cancer conditions. Both of them are widely published and have a very busy clinical practice of seeing patients with hereditary conditions. So thank you both for helping putting this course together. First, let me just introduce Dr. Steele, our chairman of our department, to also say a few welcoming words, and we'll then go right into the course. Dr. Steele.
Thank you, David. I won't take up much time, but just welcome to, whether it's virtual or in person, to beautiful Cleveland, Ohio. As you can see, the sun is shining. It's a Friday, and we're super excited to have this 8th annual edition of the Hereditary Day, and with a twist of the young onset. And so, again, congratulations to Carol and Brandie and David. And just a word for all of you who know that Dr. Liska recently took over as the head of Weiss and really partnering with all of the experts in the field. And thank you so much to Carol and all the rest of the staff who are really mentoring and working together to make sure that we are doing the best that we can for all of our patients out there. As everybody knows, that cancer affects everyone, so we're super excited to continue this tradition of having a patient day as well as a family day, and really understanding how cancer affects families. And so I hope that everybody gets an opportunity to have this as interactive as possible. We're looking, as David said, to be able to have maybe a hybrid next year or whatever, so we can get together, but really take this opportunity we want to show you what is going on and some of the advances and some of the things where we can help you, and some of the things that are going on behind the scenes. But really, let's make this as interactive as possible since we can't be together. So with that, I'll end, and congratulations, everybody. Have a wonderful day.
Thank you so much, Dr. Steele. And again, thank you all for attending. And like Dr. Steele said, this event is really one of the highlights of our year. And really, it's about you patients and families. And this is all for you. And so please participate. We will have, after each one of our sessions, we have 3 sessions that are focused on different aspects of young onset and hereditary cancer. And after each session, we'll have time for questions and discussions. We will have our first session will be on young onset colorectal cancer, nature and nurture, to try to understand sort of the factors underlying it. And Brandie Leach will be moderating that session. So without further ado, let us get started. And Brandie, the floor is yours.
Thank you so much, Dr. Liska, and good morning and welcome to everyone. We're so excited to have you here with us. We're excited to hear from our first speaker, from Dr. Stephanie Schmit. She is a new team member to us in this past year and one of our staff scientists here. And she's going to be talking to us about this alarming rising trend of colorectal cancer in young individuals and understanding who's at risk. So Dr. Schmit, the floor is yours.
Thank you. Okay. Well, good morning, everyone, and happy Friday. Thank you for including me, as Brandie mentioned, a new member of the team here. Just joined the Cleveland Clinic last summer. I'm a cancer epidemiologist and sit in the Genomic Medicine Institute of the Lerner Research Institute here. So I'm going to set the stage for today, framing the backdrop of what's happening in terms of the epidemiology and population trends of colorectal cancer rates here in the US, but as Dr. Liska mentioned, also this is a trend worldwide. As a reminder, colorectal cancer typically develops from a precancerous lesion, an adenomatous polyp inside the large intestine or the rectum, and progresses into carcinoma through a series of ordered molecular and genetic events, eventually growing into the inner wall of the colon or rectum and expanding to the outer layers, and ultimately growing into the blood vessels or lymph vessels, allowing it to metastasize or travel and spread throughout the body. In the US, this figure shows you on the top the incidence or new cases of colorectal cancer, and the bottom shows you the estimated cancer deaths in the US. And you can see that colon and rectal cancers among males and females is the third most common cancer. And in terms of cancer deaths, it's the third leading cause of cancer-related deaths among both sexes. Overall, for colorectal cancer, the incidence and mortality have decreased dramatically over the past several decades. You can see that male incidence and mortality are higher overall than in females. And you can see this rapid decline, which is mostly due to changes in underlying risk factors, as well as the increase and uptake of screening colonoscopy. And you can see over here on the right-hand side that the increase in colonoscopy trending since the turn of the century, increasing up, has really led to some of the rapid declines that we've seen overall in colorectal cancer in terms of incidence or new cases developing here in the US. And it's important to point out that there are age-specific incidence rates that change over the age course for an individual. So you'll see that colorectal cancer in the young is, in terms of absolute numbers, is relatively less common than it is in older individuals. And so here we're defining young-onset colorectal cancer as a cancer that occurs in individuals diagnosed at the age under 50. And so you can see here that age group is mostly affected in this range from age 25 up until 50. And there's an increase in the incidence when you measure this in the rate per 100,000 individuals in the population that increases across these age groups, starting to near closer to the range 50 and up as you get into the 40 to 49 year bracket. So this is really, this group from 40 to 49 is where we see the highest rates among the young onset population. But the point here is to show that still in absolute numbers, and still quite a bit lower than in the older onset individuals. But we have noticed that over the years that the median age at colorectal cancer diagnosis is decreasing. And there's a combination of factors leading to that, which include the increase in colonoscopy screening in the older onset population, changes in risk factors, and this alarming trend that we're now recognizing in the increasing incidence of young onset colorectal cancer specifically. So you can see here on the left, you have the incidence or new cases of cancer and the mortality. So the death rate among individuals who are diagnosed with cancer in this age range from children up through the age of 49. And you can see here on the left that we have seen over a 50% increase over the past couple of decades since 1994 in the incidence of colorectal cancer in this age group, with in absolute numbers affecting males higher than in females. And the increase is around 2 to 3% per year. And this is really that underlying a really alarming trend that even though the absolute numbers are still low, the relative increase is incredibly alarming, and we need to get ahead of this curve. And one of the major challenges here is that you can see the colon as colon cancer shown on the left and rectal cancer on the right, that the percent change in the incidence rate by group is very different. And so we actually have data supporting what has happened in the change from 2010 to 2020, but we can use models to tell us what we anticipate is going to happen between 2020 and 2030. And you can see that the rapid increases are affecting both in colon and rectal cancers, the highest among the 20 to 34 age group, but you still see an important increase and change in the 35 to 49-year-old group, and we're seeing and expecting to see continued decreases in the older onset group. In terms of the overall burden, about 12% of colorectal cancer cases occur in the age group less than 50, but this still accounts for about 50 colorectal cancer cases per day in the US. And this doesn't even account for the same trend that's being seen, especially in more westernized countries worldwide. And a very important issue is that about 60% of these cases are being diagnosed at stages 3 or 4 or advanced stage. And there's some indication that there may be more aggressive biology to the disease. And unfortunately, in terms of causes of death, and in this age group, colorectal cancer is the leading cause of cancer-related death among men and the fourth leading cause among women. One thing we know about colorectal cancer is that there are what we call sporadic cases, so cases that occur typically at older ages of onset, but also in the younger age bracket, but that the individuals don't have a family history and no identifiable germline or inherited mutation that's passed through families and underlies hereditary cancer syndrome. And then there's also a group of cancers that might be considered familial, where we can't identify a hereditary mutation, but there is a family history of disease, especially in a first-degree relative. And then there's a set of cancers that are known to be caused by familial cancer syndromes. And what I want to point out here, and I don't want to steal Brandie's thunder, so I'll just talk about this for 1 second, is that basically in those aged less than 50 years, certainly we know that a larger proportion are due to familial cancer syndromes, but still about 80% of the younger onset cancers do not have an underlying pathogenic mutation. And it's these sporadic cancers that are really driving this increase, and there is not as much of a change in terms of the rates of underlying hereditary mutations. So in colorectal cancer overall, we have it's a very complex disease with many different constellations of risk factors that in any given individual may be a combination of those factors that goes on to lead to increased risk for developing the disease. From age, race, ethnicity, family history, obesity, diet, which you'll hear more about in this session, physical inactivity, IBD and inflammatory bowel disease, smoking and alcohol consumption, we know are factors that play into colorectal cancer overall. And many of these factors are also important in terms of young onset colorectal cancer, but there are hypotheses surrounding very unique additional factors that may play in to a different extent in young onset versus older onset disease. And some of those revolve around the microbiome, which you'll also hear about during this session, as well as birth cohort or generational effects, where individuals of the age range, for example, 40 to 50, 30 years ago, are experiencing different sets of exposures than 40 to 50-year-olds today are. And so there's a lot of work in this space to try to help us understand what are the unique factors leading to increases in young onset colorectal cancer. And I wish we had the answer, but we don't. This is an active area of investigation where many of the factors that we just discussed that are important for colorectal cancer overall are at play, perhaps in different relative proportions. But this focus on the birth cohort or generation effects, which are really focused on secular trends, are sort of one of the major underlying drivers of research currently. And so the thought is that there's early life exposures, either in prenatal, perinatal, neonatal, and young adults and adolescents that are to known colorectal cancer risk factors and other factors that influence this increase in risk. An important issue is the Western style diet, which incorporates processed meat, fast foods, and the other elements you see listed here, which have a variety of different effects on the body, including changes in the gut microbiomes. I'm looking forward to hearing some of the detailed work that's going on in these spaces later in this session. But there are also hypotheses surrounding factors you wouldn't even imagine around the increase in C-section rates in terms of pregnancies, bottle versus breastfeeding, and other factors in terms of influences of the immune response. And so, and this is everything up to adverse social conditions and systemic racism. So you can see that there's not one factor or one even small set of factors that's leading to this increase. And what we're trying to figure out now on the research side is what are the factors and the full constellation of factors that contribute, as well as what are their relative contributions, what's more important than others. And so there are system and institutional level factors, the built environment that we as humans in society have created in terms of food access, housing and access to care, individual level factors, which are both social, cultural, as well as biological, and inherently the biology and genetics of an individual. And so all of these layers interact together to help create this constellation of factors increasing risk for early onset colorectal cancer. We're just trying to fill in the pieces of what exactly are the important components and to what extent do they play a role. In terms of the public health burden, what we can do right now is sort of a threefold approach where we have a focus on education, raising awareness, kind of like what we're trying to do today, both among patients and providers, promoting screening according to guidelines, but also thinking ahead in terms of research of where we might want to move the needle in terms of screening, allowing for early detection, and some innovative approaches to understand how can we help the young onset colorectal cancer population and also get ahead of the trend. So this is an interesting survey that was done by the Colon Cancer Alliance. It's called the Never Too Young survey. And it shows you this issue of an importance of awareness. And so over 80% of patients or their family members reported that there were at least 3 symptoms of colorectal cancer prior to their diagnosis. There was a delay in going to the doctor. It took more than 3/4 saw at least 2 doctors before getting the correct diagnosis, 40% feeling their symptoms were dismissed. And then that ultimately leads to a later stage of diagnosis. So this just highlights and underscores the importance of awareness, both from a patient and from a provider and physician perspective. Recently, the recommended age to start screening in the general population has decreased from age 50 down to age 45, both from recommendations of the American Cancer Society and the U.S. Preventive Services Task Force. And this has been underscored by the fact that the colorectal cancer risk among 45 to 49-year-olds now is similar to those in the early 90s in the age range of 50 to 54. And we're seeing that sporadic young onset colorectal cancer, as I've described in previous figures, still is accounting for a larger and larger proportion of colorectal cancer cases. And these patients tend to present more often with later stage disease, in part due to some of the diagnostic delays that I just highlighted. And so there are some thoughts that we may be seeing a shift or hoping to have a shift to an age to start screening at age 40 at some point in the future, but that is still sort of an active area of investigation and thinking about balancing healthcare resources and the ability to have sensitivity in detecting this disease. So I'll close with just one final comment on the research side is what are we doing in terms of screening and how can we start to move the needle in identifying young onset colorectal cancer and targeting the population who really needs early screening. So this is a busy figure, and I'll orient you quickly. So this shows you a risk model that incorporates genetic factors, family history, so you'll see family history on the left, no family history on the right, lifestyle factors such as physical activity and diet and environmental factors into a single model where you can weight the relative importance of these factors based on what we've seen in the populations overall and create for an individual patient a risk score, which is relative to others in the population on a scale from 0 to 100. And so what we're seeing if we focus here on group on the left of individuals who have a family history, this risk score, also you'll hear it called a polygenic risk score, shows you from 0 to 100 where an individual lies. And then on the y-axis, you have the recommended starting age for screening. And so you'll see women in red and men in blue, which reflects the difference in incidence overall. And those who have a high risk score really could be recommended to start screening at an earlier age, compared to those who have a low risk score, even with a family history, maybe don't need to be screened as early. And in the setting of no family history or sporadic colorectal cancer, and this relates to both young onset and older onset, still there's sort of this stratified range where when this was published, the recommended starting age for screening was age 50, now it's down to 45. But there's clearly a stratification of individuals across risk, which tell us that, hey, maybe not everybody needs to be screened at the same age, but those with the highest risk, even at younger ages, should be screened earlier. And that would allow us to then better allocate the healthcare resources and target them to the right people at the right time. So this is an ongoing area of research that our lab participates in, as well as others, that you'll hear from today. And it's just a really exciting area where we can make a big impact in helping to get ahead of this curve. So with that, I will end and turn it back over to Brandie.
Thank you so much, Dr. Schmit. We really appreciate your presentation this morning. All right, so I'm going to be addressing this morning who should undergo genetic testing and why. All right, so I want to take just a quick moment to talk about different types of genetic testing. If you are an individual who has been diagnosed with a cancer, there may be two different types of genetic testing that are offered to you over the course of your treatment. So one of those might relate to what we call somatic mutations. So these are mutations or genetic abnormalities that are acquired within a specific tissue. So in this case, we would be talking about the colon. So these are the actual mutations that cause the cancer. They are confined to the cancer or tumor itself. They do not cause increased risk of other types of cancer. And these are mutations that are not passed on to other members of the family. So they are mutations that remain confined just within the cancer itself. It may be that your oncologist orders some genetic testing of the tumor to help determine which mutations are present in the tumor to help guide treatment decisions. On the other hand, what this presentation will focus on today are what we call germline mutations. So these are genetic abnormalities that are present from the very sperm and/or egg that made you. They are mutations that are present in every cell in the body, and they are mutations that relate to predisposition to cancer risk. These are also the mutations that can be passed on then to children, or that can be passed from generation to generation. So today's talk will be focusing on these germline mutations. So why it's important for us to clarify if someone has a hereditary cause for their cancer are for multiple reasons. One is it can help to give an understanding of why someone developed their current cancer. I know a lot of times questions we hear, why did this happen to me? And sometimes this can help provide the answer. There can also be treatment implications, both for mutations found in the tumor as well as in the germline for treatment. So for example, if we find a BRCA mutation, that may be an individual who's eligible for treatment with PARP inhibitors, or if an individual has Lynch syndrome, they may qualify for immunotherapy to treat their cancer. So we're now moving into the realm that these mutations help inform treatment decisions. It can also help us to clarify if someone has an increased risk of developing another cancer in the future, whether that's a second colon or rectal cancer or cancer outside of the colon and rectum, so that as your providers, we can use that information to guide how we are doing screening and prevention. And then also important because it can help us to illuminate if there is potential increased cancer risk for family members and any screening that we need to be doing for family members. So Dr. Schmit, showed you a very similar pie chart like this. So I just want to dive into this a little further. The vast majority of people who develop common types of cancers fall into this sporadic piece of the pie here. That means as we all age, we're all exposed to things as our cells make mistakes while they're copying themselves. We all have an increased risk of developing cancer. Most people have no family history of the disease, and most often we think of this as cancer related to aging. And then there's another 20% of the pie here where individuals have familial clustering of cancer. So this is maybe where we see multiple relatives with the same type of cancer. They may or may not be at young ages. And this is really where those polygenic risk scores that Dr. Schmit talked about can be helpful for us in sorting out risk. Unfortunately, at this time, there is no one gene that has been implicated in familial clustering of colorectal cancer. It is probably due to multiple genetic factors, as well as lifestyle and environment that is shared in a family that's causing the increased cancer risk. And then this last little purple piece of the pie are the hereditary syndromes. So these are the individuals who have one gene mutation that is being passed from generation to generation that is increasing not only colorectal cancer risk, but often other types of cancer. And these are also the individuals who we tend to see diagnosed at a very young age. So just to put it in perspective, the pie chart is a general overview, but we know for common types of cancer how prevalent the inherited cancer syndromes are. So to contrast, ovarian cancer is one that we know has a very high genetic component. Up to about 25% of women with ovarian cancer have a genetic cause. When we look at colorectal cancer, it's about 10% of individuals overall with colorectal cancer that have a hereditary cause. And in those under the age of 50, it's about 16 to 18% of individuals. We can break this down a little further. So in 2017, there was a publication out of the Ohio Colorectal Cancer Prevention Initiative, which we participated in, and perhaps some of you on this call also participated in, where we enrolled any individual newly diagnosed with colorectal cancer. We did genetic testing on all individuals diagnosed less than age 50. And we also did screening tests on the cancer itself for the most common inherited colorectal cancer condition called Lynch syndrome. So there were some screening tests called MSI and IHC that were done on the tumor to help sort out who might have a higher risk of having Lynch syndrome. And this breaks down among the 16% of individuals less than age 50, what we found on the genetic testing. So not surprisingly, about half of individuals in this study had Lynch syndrome, which is the most common inherited colorectal cancer condition. We also found a number of individuals with APC mutation. So this is the gene that causes familial adenomatous polyposis. We also found a very common mutation in the APC gene called I1307K. So this is very common among Ashkenazi Jewish individuals and is associated with a twofold increased risk of colorectal cancer. And then the MUTYH gene causes a more rare form of adenomatous polyposis that can look similar to FAP. And then more rarely, we found some patients with juvenile polyposis. So these results in this section of the pie were not surprising. But what was really interesting to us is that we found mutations in genes that we don't typically associate with colorectal cancer risk, including in the BRCA1 and BRCA2 genes. So two genes we typically think of associated with breast and ovarian cancer risk. We also identified ATM and CHEK2 mutations. So ATM has association with breast and pancreatic cancer risk. CHEK2 primarily with breast cancer risk, although potentially colorectal cancer. PALB2 is a gene associated with pancreatic cancer risk and breast cancer risk. And then CDKN2A is a gene actually associated with pancreatic cancer risk and melanoma. So these individuals, this really created a significant swing in what sort of future cancer risk we predicted for them and what sort of future screening recommendations we had for them and their family members. So it really highlighted to us that it's important for individuals diagnosed with colorectal cancer at a young age that we need to be looking at a wide variety of genes related to cancer risk, not just those associated with colorectal cancer. My screen's frozen. So in terms of who should be tested, any family member with a known gene mutation in the family is really someone who should be seen for genetic counseling and genetic testing. These are the individuals at the highest risk of having a hereditary cancer condition. Anyone diagnosed with colorectal or endometrial cancer less than age 50, or anyone with colorectal or endometrial cancer and another Lynch syndrome related cancer, which I've spelled out down below here, regardless of the ages at which the individual was diagnosed. And then any individual with colorectal or endometrial cancer who has a significant family history, meaning there are multiple relatives with colorectal cancer or another relative with colorectal cancer who was diagnosed young. As I had touched on earlier, there are screening tests that we can do on colorectal cancers for Lynch syndrome called MSI and IHC. And if those tests are abnormal, those are individuals who should be seen for genetic testing. At most large hospitals, these tests are routinely done at the time of surgery to remove a colon cancer and are typically monitored by healthcare providers at that system. So here at Cleveland Clinic, all MSI and IHC results are monitored by myself, and we follow up on those abnormal results. And then any patient who has multiple colon polyps, so greater than 10 adenomatous polyps, or more than 2 very rare types of polyps called hamartomatous polyps. Just want to take a quick second to walk you through different types of germline genetic testing. So if you are an individual who has been tested yourself and maybe was tested a while ago, it might be there are some newer technologies now that could be of benefit if your prior testing was uninformative. So the way I think about genes is I equate them to being like books. So there are different ways that we can look at these books. For individuals who have a known hereditary cancer syndrome in their family, we know exactly in the book where the typo is that caused the cancer risk in the family. So if, for example, you have a father who has Lynch syndrome and we know what his mutation is, we can go exactly to that spot in your Lynch syndrome gene and look for the abnormality. So we're looking just for one single abnormality. Prior to 2013, we used a technology called Sanger sequencing and large rearrangement analysis. It's a gold star technology. It is very thorough. It allowed us to read through the entire book to look for any spelling errors or missing sentences or even missing chapters. But it was a very labor-intensive technology and very expensive, so we were often limited to reading just 1 or 2 books. This was largely replaced in 2013 with what's called next-generation sequencing, which allows us to look at many books or many genes at one time. So this is similar to that OCCPI study that I showed you earlier, where we were looking routinely at 35 genes at one time related to cancer risk. So it's a much cheaper and much faster technology than the Sanger sequencing and gives us much more information at a cheaper cost. So I would say right now, the majority of genetic tests we are running fall in this next generation sequencing category. One day we anticipate this will be replaced by whole exome or whole genome sequencing, where we are looking at all of our 20 to 30,000 genes at one time to look for mutations in any of those genes. And in some cases, that may be mutations that relate not only to cancer risk, but potentially to other types of health conditions as well. Important to highlight, if you are going to do genetic testing, it is strongly encouraged that you do that in the setting of genetic counseling. So we are healthcare providers with master's degrees in medical genetics or genetic counseling. And our whole job is to assess personal and family histories to identify who might have hereditary cancer risk, and then use that risk assessment to help inform the individual of their risk of developing cancer, the risks, benefits, and limitations of doing genetic testing, and then ordering and interpreting that genetic test result in the context of an individual's personal and family history. So I thank you so much for your time this morning. I am now going to stop sharing my screen. And we will now pass it over to Dr. Cresci. So she is a dietitian who works with our team, and she will be sharing with us information about how nutrition affects risk for colorectal cancer.
Okay, thank you so much. Good morning, everyone, and I'm really excited to participate today to present to you what's kind of known in the field regarding nutrition and its effect on the risk for colorectal cancer. So there's many factors, as you've heard already, about that are associated with the pathogenesis of colorectal cancer. And I'm going to focus on diet, and not just diet, but there's other components that typically coincide with diet, such as an individual's nutritional status. So whether you're malnourished or not well nourished. And there's a lot of data now that's coming out regarding physical activity. But for the sake of my talk, I'm just going to focus on the diet component. So when we think about diet, it really can get confusing, and every day there's different information that comes out and really confuses the consumer on what should I eat? Is this good? Is this bad? And it's not that the information that you had before is wrong. It's just that now we've learned new information that has kind of changed the story a little bit. But I'm going to focus on the components that you see here in this slide. So for many, many years now, there's been a lot of investigation looking at the association of red meat consumption and the risk for colorectal cancer. And this is a slide that's showing, it comes from this review paper that you can see in the bottom right-hand corner that comes out of the journal called Nutrients. And in this table, it's just listing the different study design type and the results of the study. And basically, there's a positive correlation with the consumption of red meat with the risk for colorectal cancer. And it's based on how much red meat you're eating. And it's not actually just red meat, there's actually processed meat as well. And in particular, we'll talk a little bit more about what are the components of red meat and processed meat and how this has been shown to be associated with colorectal cancer risk. This is another review paper that also has this nice table that, again, you can see on the left-hand column that these studies go back to the 1990s. And so there are different types of studies where they're case control, they match people with colorectal cancer against people without. And then these meta-analyses are basically more intense reviews where they pull together several studies on the same topic and look for associations. And again, here it's just emphasizing that on the right-hand column, the results, you can see that red meat consumption unfavorably affects the risk for colorectal cancer. So what is it about meat? And basically it's, come out that there's about a 33% increased incidence of colorectal cancer for people who consume red meat and processed meats. So it could be multifactorial. So people who consume a lot of red meat or processed meats, it could be an indirect effect in the fact that if their diet is really consisting of these types of meats, then they're less likely to be consuming a lot of vegetables, fruits, and fresh fruits and vegetables have lots of fiber. And we'll talk about fiber in a few minutes. And they're more likely to be consuming a diet that's higher in saturated fat, which is contained in any type of animal based protein, and refined starches. So basically, these refined starches do not have fiber, and they may be consuming more eggs and cheese. So that's an indirect effect. But what's research has shown is that particularly with red meat, is the preparation method can result in the end product of the meat that the person consumes to contain different carcinogens. So this is really related to meat that's been grilled, well done, at very high temperatures. And what this results in the meat is that there's what's called heterocyclic amines and polycyclic amines. And these have been shown to be linked with higher risk of colorectal cancer, and particularly in people who are genetically predisposed to colorectal cancer. Now, in processed meats, and I have a little picture up there, so what I'm talking about are these deli meats, hot dogs, salami, lunch meats, anything processed, cured. So what these meats contain are nitrates and nitrites, and these are contained in these food products because they are preservative. However, they've been linked with causing damage to your DNA structure. And when you have this DNA structure damage, this is where it can result in different mutations and be linked with the increased risk for cancer. Okay, so the next food group I'm going to talk about is alcohol. It's not really a food group, but we think about alcohol because a lot of people, with your diet, because a lot of people do consume alcohol along with their diet. And so over the last several years, there's been investigations, again, these meta-analyses, or where there's pooling of different studies together to try to see if there's an association. And there has been a positive, strong association for consumption of alcohol and the risk for colorectal cancer. And so it's really linked with how much alcohol you're drinking. And it's greater than 1 drink per day was shown in this top row that you can see, or greater or equal to 2 drinks per day. And so per the National Institutes of Health, that's what the standard moderation for alcohol is for females is 1 or less drink per day, and for males, 2 or less drinks per day. So it's when you start to exceed this threshold is where you can have these increased risks. And there really hasn't been necessarily definitive of what type of alcohol you're consuming. There's certainly been more research over the years looking at different consumption of like red wines versus white wine, beer versus distilled drinks. My area of research is with gut microbiota and fermentation. And one thing we do know is that alcohol that's produced by fermentation, so this would be like your wine and your beer, does result in different organic acids that's in the alcohol that you're consuming, as opposed to the different byproducts that are there in distilled drinks. But either way, the risk for colorectal cancer does lie within the amount of how much alcohol you're consuming. Now, this doesn't, vitamin D and calcium, it's been investigated, but the evidence isn't as strong for a recommendation necessarily for this. However, looking at vitamin D, that's the top panel. There's been, again, pooled studies where they've looked at not just in the United States, but also in Europe, and really have found that looking at people's consumption of vitamin D, if they have a low consumption, it's a higher risk for colorectal cancer, and vice versa. Looking at calcium, again, there seems to be a little bit of signal in some studies showing that lower calcium intake leads to a higher recurrence of adenomas, or the higher risk for colorectal cancer, and that people who are taking supplementation with calcium, in this one study, it's the third row down there, that they had no effect on the incidence of colorectal cancer. So it really kind of, some of these go back and forth. So not really strong evidence, but again, it's the way that the studies are designed. There could be something going on, but not enough to make a clear recommendation at this point. Okay, so dietary fat in colorectal cancer. So definitely there's a positive association between obesity and colorectal cancer risk. So the more obese somebody is, the higher risk they have. And, you know, what is the reason for obesity and colorectal cancer? And so people with obesity have in their bloodstream have a low-grade inflammation, and where this inflammation is coming from is not necessarily confirmed, but there's many areas in the body it can be coming from. It can be coming from our bacteria and other microbes within the intestine. It can be associated with the type of diet that you take, because there is an association with high fat diets and obesity and this low grade inflammation. So when we think about the different types of fats, and I hate to classify fat as any food as good or bad, but in this situation, it's kind of in the context of inflammation. And so polyunsaturated fats, which are fats that are liquid at room temperature, so they typically come from our plant-based sources of fats, are known to have more of an anti-inflammatory profile. And in particular, these are, but this also includes like fish oils. So that doesn't come from plant-based, but they're still polyunsaturated fats and liquid at room temperature. And so these fats have been studied in a number of different types of situations and known to cause less inflammation. And it's really through the way that our body metabolizes them. Saturated fats, these are fats that are solid at room temperature. So this includes any type of fat found in an animal type product. It also includes palm and coconut oil. And I know there's a lot of, in some realms, there's a lot of information out there that coconut oil is supposed to be good for you, but it is important to know that coconut oil is saturated fat. And these are known to be pro-inflammatory. And one thing about fats, you know, why are these more pro-inflammatory? So one thing about fats is that not only the way that our body metabolizes the difference between the two types of fats, but fat alters the bile flow that comes into our intestinal tract. So our liver produces bile that gets released through the gallbladder into the intestine. And this bile is very important to help us digest and absorb fats. The more fat in your diet, the more bile flow that's going to be coming. And what happens is that our gut microbiota, which we're going to hear a little bit more about that in the next talk, but they also are able to metabolize these different types of fats and these different types of bile acids that result. And there's a type of bile acid called secondary bile acids that are known to be harmful in the intestinal tract, and those are the ones that are more linked to the risk of colorectal cancer. So it's kind of multifactorial of how fat can potentially increase the risk for colorectal cancer. Okay, so fiber. So I have this nice, beautiful picture of different sources of fiber. I have listed here all the different types of fibers, names for fibers that you might find on your food labels. You know, it's very confusing trying to think about what is fiber. But we know, and we've all heard, fiber is good for us. We need to eat more fiber. So how much fiber should we eat? Well, I'll get to that in a minute. So here is looking at the data, looking at the association of fiber intake and the risk for colorectal cancer. So again, the different types of studies, but again, mostly these observational studies, but there have been some interventional studies and showing that dietary fiber has been associated with the decreased risk of colorectal cancer. Some studies have shown no protective effect of fiber. And so it's, again, this is this area that gets really confusing and you walk away with like, should I eat fiber or shouldn't I eat fiber? What's going on here? So what's recommended for all people, doesn't matter what's going on with you, how much fiber you should consume. So there's no, from the USDA dietary recommendations, there's recommendations, but there's no recommended daily intake for fiber. But what's recommended is that for males, and less than 50 years old to consume 38 grams per day, and for females, 25 grams per day. And if you're more than 50 years old, 30 grams versus 21 for male versus female. And when we look at analyses and we do these evaluations of our of Americans as a whole, most Americans consume only half of this recommended amount of fiber. And not just with colorectal cancer, but other different pathologies, low intakes of fiber are associated with different health concerns. So like I said, there's many types of fiber. And so when you think about your different foods, what I want you to think about are these different types of fiber that are contained in them. So insoluble fibers, so this is when you have fresh fruits and vegetables and you have the skin, or you're eating the seeds, some like strawberries contain the seeds, or whole grains. These are sources of insoluble fiber. And what that helps with, it's a bulking agent. So it helps promote bowel regularity. Foods also contain soluble fibers. So this is a type of fiber that's very viscous. And so it's like you think about something you're cooking like oatmeal, how it gets really gelatinous and absorbs the water. Oat bran, barley, different nuts and seeds also have soluble fiber, as well as lots of fruits and vegetables like apples are a very good source of soluble fiber. The inside, the outside, the skin is insoluble fiber. So soluble fibers have been linked with, improving blood cholesterol levels and helping with glycemic response. Fermentable fibers, this is fiber that they're typically soluble fibers, but not every soluble fiber is fermentable. And when I talk about fermentable, that is linked with your gut microbiota, so the microbes within your intestinal tract. So when you think about all different types of fibers, what happens is they're a type of carbohydrate or polysaccharide that we as the host, our body, we don't have the enzymes to digest these different sources of carbohydrate. So they escape digestion and they move to our distal gut and meet up with the gut microbiota. So I just want to say, call this attention to these different types of fibers, and that paper that I showed that showed variable effects of fiber. They didn't really, and a lot of those studies didn't differentiate between the different types of fibers that someone was consuming. So just with the gut microbiota, you're going to hear more about this in the next talk, so I'm not going to go into a lot of detail. But like I mentioned, most of our, so these fermentable fibers get to our distal part of our intestine, so the colon. And this is where the majority of our microbes are within our colon. So as this diagram is just showing a picture of how these different fibers that we consume in our diet escape digestion, get to our distal part of our intestine, and that's where these microbes are able to, they have the enzymes to break down this fiber, and they're able to metabolize it, and as a result of that, they produce these beneficial byproducts to us, the host. And in particular, one is these are called short chain fatty acids, and one of them in particular is called butyrate. So butyrate has known to have many beneficial biological roles in the body. It's the major fuel source for our colon cells. It helps with water and electrolyte absorption. It helps modulate immune function. And in many studies, epidemiologic studies, it's been shown to, when you have a lot of butyrate within your gut lumen, there's a decreased incidence of colorectal cancer and other problems such as inflammatory bowel disease. And butyrate in particular can affect the DNA structure in a positive way. So it can alter the expression of anti-inflammatory genes and decrease their expression there in our intestine. When there's decreased butyrate, like I mentioned, there's more pathology that's been associated. There's more cell death. There's more inflammation, more mucosal atrophy. And so there's actually been studies, particularly in people with inflammatory bowel disease, when we give back butyrate or other short chain fatty acids, it's able to help reverse some of these disease and clinical signs and symptoms of pathology. So the last nutrient I want to talk about is folic acid or vitamin B9. And there's been more research now looking at folic acid. It's an important B vitamin. It's involved with cell growth, and it's involved with DNA synthesis, its repair, and its methylation. And so there's lots of foods that contain folic acid in our diet, such as leafy green vegetables, such as spinach and kale. Legumes are a good source, citrus fruits, but you can also get it through supplementation, and it's in food fortification as well. So a lot of foods are fortified with folic acid. Here's just a slide showing some of the data. This one actually dates back to the 1990s, early 2000s, showing some associations between folic acid and the risk for colorectal cancer. But if you look on the right-hand column with the results, there's other things associated with the folic acid, such as fiber, because legumes also are a good source of folic acid, alcohol consumption. So some of these things that we've already discussed. But folic acid has been linked with this association as well. But there's not a super strong recommendation to start taking folic acid supplementation. Okay, so I just want to end that I hope I've reviewed for you the different components of diet that have been associated with higher risk for colorectal cancer. Some recommendations I have to help decrease your risk for colorectal cancer through your diet would be to avoid meats, processed meats in particular. Check the label if they say nitrates, cured or salted, and even foods that say nitrate free, skip those foods as well. They're not any better for you than the others. Avoid grilled meats that are charred. Avoid that at all costs. And really start thinking about having more meatless days, a couple days a week. Don't eat meat at all. Just get your protein from plant-based proteins. So these are your legumes that are very good source of that. And really emphasize your diet to be more rich in these fruits and vegetables that are and whole grains. And in particular, you want to look for foods that contain resistant starch. So resistant starch is the one that is highly fermented by the gut microbiota to help produce some of these short chain fatty acids, in particular butyrate. And that includes things like potatoes and rice are very good sources of that. And you want to really look at your fiber intake and shoot to try to consume about 25 to 30 grams per day with the mixture of the insoluble and soluble fibers. And limit your alcohol intake on top of all of this. Okay, so that's all I have. I'm going to stop there and turn it back over to Brandie.
Thank you so much, Dr. Cresci. I'm now going to introduce Dr. Kanika Nair. She is currently one of our fellows in our Cancer Institute, and she will be joining us this summer as a staff provider here. She'll be speaking to us about the microbiome. Go ahead, Dr. Nair.
Hi, good morning. Thank you, Brandie. So today I'll be discussing the role that intestinal bacteria play in colorectal cancer. So in a healthy state, there's a perfect balance between the intestinal bacteria and the immune system. The bacteria interact directly with the immune system. As you can see here, there's many different bacteria that make up this microbiome and are involved in regulating this balance. These cells that make up the intestinal lining serve as an interface between the bacteria and our immune system. As we move along the intestine, different portions of the intestine have different microorganisms that are involved in regulating that balance. So there are a number of factors that affect the microbiome, and this is actually a depiction by Dr. Cresci, who we just heard from. So some of these factors include birthing and infant feeding methods, exposure to stress, environment, diet, medications, geography, age, as well as comorbid diseases. So in colorectal cancer, there is an imbalance of intestinal bacteria that results in the breakdown of the cell barrier in the colon wall. This enables bacteria, fungi, and other microorganisms to enter, triggering inflammation and promoting DNA damage, which can then lead to cancer. In this picture, you can see one of the bacteria that is implicated called Bacteroides fragilis, and it coats the tumor and it can recruit other bacteria to create a biofilm around the tumor. It also recruits immune cells and promotes inflammation. These biofilms promote to a pro-cancerous state. Biofilms have been implicated in sporadic colorectal cancer, as we've heard about from Brandie, that can occur outside of a hereditary disorder, as well as inflammatory bowel diseases, ulcerative colitis, and Crohn's disease. Biofilms are more common in right-sided colon cancer, which we know generally carry a worse prognosis. One study that's looking at this is the Cosmo Colorectal Cancer study from Georgetown University. They're studying the tumor microbiome in 64 patients who were diagnosed with colorectal cancer in younger patients, younger than the age of 45, and comparing it to another 64 patients diagnosed after the age of 65. So the preliminary findings that were presented last year on 31 patients in this study show 478 different bacterial and fungal species that were identified in the tumor microbiome. The average age of the younger patients in this study was approximately 39 years, and of older patients was 73 years. The specimens that they collected and used, evaluated, were primarily from the primary tumor site that were obtained either during a biopsy or surgical resection of the tumor. Results are notable for two bacteria, Fusobacterium nucleatum, which was found more frequently in younger patients, while Moraxella osloensis was detected more frequently in older patients. Both older and younger patients had diverse populations of over 40 species of organisms identified in the tumor microbiome. There are a number of other studies that have explored the tumor microbiome in patients with colorectal cancer, and they've also identified Fusobacterium as a common organism. Fusobacterium has been associated with increased growth of colorectal cancer tumors, as well as lymph node and liver metastases, proximal tumor location, molecular alterations like the tumor being MSI high or having a BRAF mutation, chemotherapy resistance, specifically to drugs like oxaliplatin, which is commonly used to treat colorectal cancer, recurrent disease, shorter survival, and improved diagnostic performances of FIT-based testing that can be used for colorectal cancer detection. Other common species that are found in the tumor microbiome include Bacteroides and Streptococcus species, which are also associated with increased colorectal cancer tumor growth and increased DNA damage that can lead to cancer. However, these are only 3 of the common bacteria that are associated with the tumor microbiome in colorectal cancer, and there are dozens, if not hundreds more. Now I'd like to tell you about the research that we're doing here at the Cleveland Clinic on the tumor microbiome in colorectal cancer. Our goal is to identify differences in the microbiome of young-onset colorectal cancer patients as compared to older-onset colorectal cancer patients. We are defining young-onset as patients whose cancer is diagnosed between the ages of 18 and 50 years, and older-onset as patients whose cancer is diagnosed after the age of 60 years. We're also looking at the differences between a healthy microbiome and one that is associated with colorectal cancer. So we are using specimens from our tumor tissue bank, and we'll analyze samples from 300 patients with colorectal cancer. Of these, half of them will be young onset patients, the other half will have late onset colorectal cancer. We will compare the microbiome from the patient's cancerous tumor sample as well as their healthy normal tissue for analysis. Additional data variables that we're collecting for each patient include demographic data, relevant past medical history and family history, such as GI illnesses, previous polyps, history on hereditary syndromes, as well as their cancer history. Medication use, such as aspirin, probiotics, and chronic antibiotic use more than 2 weeks, as these can all affect the intestinal bacteria. The type of bowel prep that was used for the procedure when the tissue sample was obtained, history of smoking, alcohol, and drug use, weight and body mass index at time of diagnosis, the clinical presentation at the cancer diagnosis, cancer staging, tumor location and pathological diagnosis, details of treatment, including chemotherapy, radiation, and surgery, mutations and biomarkers, as well as the response to treatment. So in the future, we look to correlate the tumor microbiome to overall survival in colorectal cancer and to identify patients that are at high risk for developing colorectal cancer by analyzing the tumor microbiome. We hope to use the tumor microbiome as a prognostic tool and ultimately to manipulate the tumor microbiome to aid in treating colorectal cancer. I'd like to acknowledge our project team with Dr. Khurana, Dr. Liska, Dr. Kamath, and Dr. Burke, as well as our research collaborators, Dr. Sangwa and Dr. Schmit, who you heard from earlier, Dr. Zhang, and then our funding is supported by Sandra and Stephen Hardis. Thank you.
Great. Thank you so much to all our speakers. So I see we do have some questions coming in. Dr. Cresci, I'm going to start with you. One of the first questions we received is, one individual indicated that they enjoy grilling on a propane grill, but rarely char the meat and wanted to know if that's okay.
Yeah, that's a good question. I think, the majority, it's really dependent on what type of meat it is. So if it's a red meat or something processed, I would avoid that or limit. So if you enjoy red meat, it's really how much you're eating it. So I would limit that to not more than 1 time per week or even less. And then, of course, yes, avoiding any of the charring. So that's good that they're not doing that.
And we also received a second question from this individual. How do you distinguish between processed and non-processed meats?
So a processed food, not just meats, but any kind of food is going to have an ingredient label. So if your food doesn't have an ingredient label, then it's not processed. So you go to the meat counter and you just see meat. It just says what kind of steak it is, what kind of chicken, if it's a breast versus a dark meat thigh. But if it has a food label that has anything listed on that, then that's processed. But I'm particularly talking about things like luncheon meats. So there's different types of lunch meats that that you may find at the deli counter that are actually the original chicken or turkey breast that's been baked. That's okay. It's the one that's processed that has the preservatives and things in it that you want to avoid.
Great, thank you. And then, of course, very important in this audience, we've had a number of individuals who have had colectomies and really struggle with fiber after having their surgery. And just wondering if you can comment on after surgery, what sort of dietary changes maybe to expect and how to reintroduce foods after surgery.
Yeah, no, that's a very good question. So, like I said, fiber is very confusing because of the different types. And actually, so the type that helps, particularly if your colon's been removed, and so you want something to absorb the fluid to help reduce your osmotic output, is more of the soluble fibers. And like I mentioned, many of these soluble fibers are also fermentable fibers. So things in particular like the fermentable fibers or resistant starches come from foods like, so if you take a potato, I'm just going to give this example because it's very simple. And it's a lot of times it's the way that the food is prepared. So if you take a potato and you bake it and then you eat the skin would be insoluble. So you want to avoid that. And even baking the potato doesn't increase the soluble fiber as much. But if you take a potato, you peel it, you boil it, and then you let it chill. So like if you're having potato salad, do you ever have that white starchy stuff on your hand, your fingers, if you're peeling the potato after you boiled it? That's the fiber. So that's a resistant starch that I'm talking about. So if you boil and chill, so same thing can happen with different types of white rice. If you boil it, you make your rice and then you chill it and it can sticky together. So that's a type of fiber that they can consume that should help with bulking, but not cause problems with the digestion issue.
Great, thank you so much. Dr. Schmit, I have a question for you. Is the rising trend of colorectal cancer in young individuals seen globally? And if it is or isn't, could that give us any clues maybe into causes of why we're seeing this rising trend?
Sure. I think Dr. Liska alluded to this in the very introduction too, that this is not just a trend that we're seeing in the US, it's definitely seen globally. And there are only a handful of countries where we don't see it as much, and these are typically those that don't have as much of the Western diet, where we're talking back to Dr. Cresci's comments of red meat intake, processed meat intake, and typically have higher physical activity. So basically the trends are the same in other countries where we're seeing the same issues surrounding obesity, Western diet with processed and red meats, and low fiber and fruit and vegetable intake. So yes, it's not US specific, it definitely is globally. And I think that gives us some hints about how important the diet is. And I think research to help us understand how the diet impacts the underlying risk, especially potentially mediated to the microbiome, is incredibly important. But yeah, it's not a US specific phenomenon.
Thank you. And then Dr. Nair or Dr. Cresci, should we be taking steps to increase the good bacteria in our digestive tract? And if so, what would be recommendations for how we could do that?
Do you want to go, Dr. Nair?
Sure. So, I think there's still a lot of research being done around this. A lot of people, there's a lot of work being done on whether probiotics are helpful or not. And from what I found, I don't know if we're quite at the point of being able to make a recommendation that, consuming these bacteria will necessarily help. I think, following a lot of the recommendations that Dr. Cresci has laid out in terms of overall what the diet should look like is probably at this point more prudent. And Dr. Cresci, I don't know if you have more to add.
No, I agree. Because probiotics, they're strain specific, and so their mechanisms of action are going to be different. And so that doesn't always translate into what's commercially available. And so to just randomly start consuming one doesn't mean that that's going to necessarily help in your particular situation where Dr. Nair's study that they're doing is going to help identify what strains may be targets, but we're not there yet. But things you can do is the diet. I already mentioned the fiber, how that really helps with support the gut microbiome. And another thing is to consume fermented foods. So these are not the alcohol, but the fermented foods like yogurt or kefir or kombucha. And so as a result of these, there's these beneficial organic acids that are also in those foods that you're also consuming at the same time.
Great, thank you. And then I see one more question, and this one's for me as it relates to genetic testing for Lynch syndrome, asking what age is appropriate for testing children. So Lynch syndrome is associated with adult onset cancer risk. So it is a condition that we really don't think about doing genetic testing for until someone reaches adulthood. And generally, we try and pair doing that genetic testing with when we would have a screening intervention. So in the case of Lynch syndrome, that would be starting colonoscopy sometime between the age of 20 to 25. So generally, we aim to do the genetic testing sometime in that same age range, because that's then going to guide if we need to start doing colonoscopies for that individual, or if they don't have the Lynch syndrome mutation in the family, if they can actually wait until age 45 to start with their screening. So I'd like to thank all of our speakers in this session. I'd like to thank our attendees for submitting their wonderful questions. We are now going to have a break until 10 o'clock.
Welcome back, everyone. So short break, and we'll continue right along with the next session here. And the next session is all about treatment of colorectal cancer in the young, and we'll learn about surgery and post-surgical concerns, and also about chemotherapy and also endoscopic methods in this session. So to start us off, we'll have Dr. Sommovilla. He's the current Church Seats Fellow in Hereditary Colorectal Cancer. So a very unique fellowship we have here at the Cleveland Clinic that was generously made possible by the Sheets family. And he has learned a lot about hereditary colorectal conditions this year, and has also helped us take care of many complicated patients. And hope many of you have gotten to meet Josh, and he'll talk to us a little bit more about some surgical questions that we discuss with all of our patients. If the colon has to be removed, how much of the colon needs to be removed, and why? So Josh, please go ahead.
Thanks everyone for coming today, and it's an honor to be able to give this talk to you. I'm going to be focusing more on the surgical aspect of things and the surgical decisions we have to make in both young patients with colorectal cancer and in patients with hereditary colorectal cancer syndromes. Rather than focusing on the specific techniques that we use, I'll be focusing on a fundamental question that we often face, which is how much of the colon do we have to remove in these situations? And so I'll start with just an example here. So imagine a 30-year-old man who presents without any prior medical issues and no family history, and goes to his primary care doctor because of constipation and blood in his bowel movements. Often this will ultimately lead to somebody undergoing a colonoscopy. And this is a picture of what you might see on a colonoscopy. This is the inside of the colon, where there's a mass on the right side of the colon that's biopsied, and it ends up showing colon cancer. So we're often faced with a few questions. What to do next for this patient? Why can't you just cut out the tumor? And what factors do we consider when we're moving forward to surgery? Now, in some cases, and Dr. Gorgun will talk about this a little bit later, there are circumstances where we do try to just cut out the tumor, but in many cases, that's not the case. So here are some of the considerations that we think about when we're considering surgery in these patients. The first is just providing the best treatment that we can for the current cancer that we know about. And that includes doing things to prevent this cancer from returning in the future, or what we call recurring. But also we have to consider what the risks are for a patient developing a second cancer in the future and minimizing that risk. And also put this in the context of quality of life choices and how to optimize quality of life after surgery. So first I'm going to focus on these first two bullet points, which is directing our treatment towards this current cancer that we know about. And so an important part of that is cancer staging. which I think Dr. Krishnamurthi is going to talk about in more detail later, so I'll go through it pretty quickly. But the stage of a cancer lets us know how advanced that cancer is and gives us important information both for prognosis and for coming up with a treatment plan. And there are a few components to staging that I'll talk about. The first is how deep the tumor has grown into the wall of the bowel. That's called a T stage. And the second is whether it involves any lymph nodes that are nearby to the tumor. So this is a picture of the colon here, and you can see these little green circles. These are the lymph nodes, and they travel along the blood vessels that feed blood to the colon, and they drain lymph tissue from the tumor, and they're often the first place that a tumor will spread. And the third part of staging is whether it's metastasized anywhere. And this is really the only part of staging that we can get a good idea of before surgery, because we can see it on imaging. The T and the N stages are things that you can really only see well under a microscope. So these are important things for us to know in giving optimal treatment for a cancer, and they enter into our surgical decisions. So just to overview large intestine anatomy quickly, because we'll be talking about it a little bit. This is a picture of the colon. The small intestine is not shown in this picture, but it kind of sits here in the middle of where the colon is. And on the right side is where the small intestine empties into the right colon, which is where you see the appendix. And the colon goes up and then across to the left side of the body as the transverse colon, comes down as the left colon. And then you have a part of the colon that's a little twisty, and that's called the sigmoid colon. And the last part of the large intestine is called the rectum. And that's about the last foot or so before your anus, where you have a bowel movement. And again, these are the lymph nodes that drain from the colon, and they travel along these blood vessels that get to it. So because of what we're talking about with staging, when we talk about doing surgery for colon cancer, we have to do what's called an oncologic resection, where we remove not just the tumor that we showed before, but also all the lymph nodes that drain from it. So the smallest surgery that we would think of doing in somebody with a tumor on the right side of the colon, like I showed in that case at the beginning, would be removing this entire right part of the colon that includes both the tumor and all these lymph nodes that drain from it. And so in colon cancer surgery, depending on where a tumor is, the kind of minimum surgeries we consider are what's called a segmental colon resection, where we would remove that part of the colon and the lymph nodes that drain from it. So that could be either a right colectomy. In some cases, if the tumor's in the transverse colon, we could do a transverse colectomy. And as we move towards the left side of the colon, you could consider a left colectomy or a sigmoid colectomy. And then in cases of rectal cancer, we would often remove the rectum. And so this brings us to the other bullet points that I talked about before, which is, in some cases, would we consider doing more surgery to minimize cancer risk in the future? And how do we balance that with quality of life decisions and deciding what type of surgery to do? And this brings up the question of preventative surgery and when we might consider it. So should we ever consider removing colon that's not involved with cancer? And a preventative or prophylactic surgery could either be considered a secondary prophylaxis, which means a person has cancer and you remove extra colon to minimize future risk, or somebody doesn't even have cancer and you remove the colon prophylactically to prevent them from developing it in the future. So back to our original case that we were talking about before in somebody with a right-sided colon cancer, when we consider doing what's called a total colectomy instead of a segmental colectomy to both treat the cancer that they have and minimize risk of cancer in the future. And there are a number of things that we consider when deciding whether to do this. This picture just shows how a person would be hooked up after these two different surgeries. So after removing the right colon, the small intestine would be hooked up directly to the transverse colon. And you can see in this figure, a person has nearly 2/3 of their colon remaining. As opposed to here, after a total colectomy, where the small intestine is hooked up directly to the rectum, where there's only about a little more than a foot of rectum remaining. And so the things that we consider in this case would be, how old is the patient? Because a young patient has theoretically more years to live and more years to develop another cancer in the future. What's the family history of colorectal cancer? What are the genetic testing results that might guide our decision making? And what impact might the extended surgery have on the risk of the operation itself, but on bowel function and quality of life in the future? And There's a few studies that help us guide these decisions. In a study that was done here at the Cleveland Clinic in patients with a very strong family history that is suspicious for Lynch syndrome who underwent surgery, we found that patients who had a segmental colectomy, about a quarter of them developed another cancer at about an average of 5 years after surgery. Whereas people who had a total colectomy, only 8% or a little less than 1 in 10 developed a second cancer in the future. So doing a extended colon resection in people who are suspected to have Lynch syndrome would substantially reduce the risk of developing another cancer in the future. Another study that was done in New York at Memorial Sloan Kettering Cancer Center with patients who had Lynch syndrome who had segmental colectomies found that about 20% of these patients developed a second cancer. But even within Lynch syndrome, there was some variability depending on what mutation they had. So Lynch syndrome, there are typically 5 mutations that make up Lynch syndrome, and some are considered to be higher risk than others. So patients with the MLH1 mutation were more likely to develop a cancer in the future, whereas patients with the MSH6 or PMS2 mutation were a little bit less likely. So these are some of the things that we consider when we think about doing an extended colectomy. And then we also have to think about what's the impact on function. So a person who has a segmental colectomy, they might have some short-term changes in their bowel function, a little bit more frequency of bowel movements, a little bit more diarrhea, but it's very unlikely to lead to long-term continence or urgency issues. Whereas patients with a total colectomy, most patients will still have pretty good function, which we would define as 4 to 6 bowel movements a day, a little bit more frequent, potentially a little bit more liquidy, but generally don't have major issues with urgency or incontinence. But it also depends a lot on what the baseline function is like. So somebody who has a lot of frequency or some continence issues before surgery, after a total colectomy, would be very likely to have substantial issues, and we would have a long conversation and think twice before doing that type of surgery and balance it against the cancer risks. So in summary, for patients with Lynch syndrome or strong suspicion of Lynch syndrome, the advantages of doing a segmental colectomy would be that you're doing a smaller and lower risk surgery that ultimately would lead to slightly better function in the future, but at the disadvantages of having a higher risk of future cancer. As opposed to this, a total colectomy would lower the risk of having a future cancer while potentially causing bigger issues for postoperative complications or for having slightly worse function in the future. And Dr. Burke is going to talk about this a little bit more later, but for all of these patients, but in particular those who might have a segmental colectomy, having really close surveillance of the remaining colon postoperatively is very important. So I mentioned before the idea of doing primary prophylaxis, and this is doing preventative surgery in somebody who doesn't even have colon cancer. And this is something that's really uncommon for us to do on somebody just based on having a strong family history, or even in people with Lynch syndrome. Usually those people we just surveil very closely with colonoscopy. Primary prophylactic surgeries are really things that we consider most in patients with polyposis syndromes who have the highest cancer risk. And the biggest example of this is familial adenomatous polyposis, or FAP. So for people here who are not familiar with FAP, this is an inherited condition where people develop hundreds to thousands of polyps in their colon. And this is a picture of a removed colon in a person with FAP, and you can see how many polyps there are there. And so they develop hundreds of thousands of polyps in the colon throughout their lifetime, but the severity of it varies. And the entire colon and rectum are at risk, but the degree of risk is variable and depends on polyp numbers, size, and the pathology that we see in polyps under the microscope. These patients are at risk for other cancers, including the stomach, small intestine, and desmoid tumors. And the surgical decisions that we make in FAP depend on a lot of these variables. But most people with FAP will develop colorectal cancer if they do not have preventative surgery. So most people will have surgery as a young adult. Because of the high cancer risk throughout the colon and rectum, the two major surgeries that we consider doing in FAP are the one that we talked about earlier, a total abdominal colectomy with ileorectal anastomosis, which leaves the rectum in place but removes the entire colon, or what's called a total proctocolectomy, which is removing the entire colon and the rectum which usually leads to creating a pouch out of the small intestine that's hooked up to the anus. So these pictures just show how the hookups look after we do these surgeries. And so when considering these two different surgeries from each other, the benefits of leaving the rectum and performing an ileorectal anastomosis, that's the top row here, is that people will have better bowel function and a better quality of life typically. And it still is a very good operation to control the polyps in the colon, and usually allows us to not perform even a temporary ileostomy bag. And the downsides of this procedure would be that it keeps the rectum in place, so there's still a risk of rectal cancer that needs to be looked for closely. The second surgery, the total proctocolectomy with pouch, is advantageous because it removes nearly all risk of colorectal cancer in the colon and rectum, and it avoids a permanent bag because we're able to make that pouch and hook it up to the anus. It offers a reasonably good quality of life, although certainly more frequent bowel movements and more continence issues compared to people who have a rectum. The downsides of performing pouch surgery is that it's a technically demanding surgery with higher complications. The function afterwards could be a little less predictable, and there's still a very small cancer risk in that small area right at the anus where there's still development of polyps and cancer is possible. And in FAP patients, these desmoid tumors are slightly more common in patients who have pouches. So typically we perform a total colectomy with ileorectal anastomosis when people don't have very bad disease in the rectum, or they have not the most severe disease in their colon, or if they're people who we deem to be at high risk of developing desmoid tumors in the future. Obviously, we don't want to leave the rectum in place when people have a known rectal cancer, or if we think they have too many polyps in the rectum that we could remove them in the future with colonoscopies. We perform the pouch surgery when people have the flip side of this, which is too many rectal polyps to keep an eye on in the future, or rectal cancer. And we avoid it when we worry about developing bad desmoid disease in the future, or if there isn't a surgeon who is trained at this procedure to perform it. In some patients with really bad function who need to have their rectums removed, or with a very low rectal cancer, we can't form a pouch, and so we still need to remove the rectum, but those patients, often all we can offer them is a permanent end ileostomy bag. So in summary, decisions about what type of surgery to do in patients who are at high risk for colorectal cancer are multifaceted, and that surgeons and patients have to balance both our current cancer treatment, if cancer is present, future risk, and quality of life concerns when coming up with a final plan. Thanks, and I'll be happy to talk about this more in the question and answer session.
Thank you very much, Josh. This was great. I'll be doing the next talk here, and we just heard about different types of surgery that are needed both for hereditary conditions and young onset colorectal cancer. And surgery really is the mainstay of treatment for colorectal cancer and for hereditary conditions. So a question that's especially applicable to young people who are undergoing surgery, young people who have cancer and have a very active life, and they have to get back to work, have to get back to school. So how can we make sure, how can we help you, and how can you help yourself bounce back faster from surgery so you can get back to doing what's important in the rest of your life? So that's what I'll be talking about. And there is a concept called enhanced recovery after surgery, and that will be the focus of my talk. So there are many different names for enhanced recovery. It was previously known as fast track surgery, meaning getting through surgery and getting through the hospitalization faster, but it has changed since then, where it's more a focus about not just getting through this faster, but getting through it better. And that's why the name that people use now the most is enhanced recovery pathways, or enhanced recovery after surgery, or ERAS. And these concepts were pioneered by colorectal surgeons, but is now really, they're all being widely used by many different surgical disciplines, not just in the US, it's all around the world. And it's really has become the standard of care for surgical treatment. And what these enhanced recovery pathways entail, they are standardized, meaning very sort of regimented for every type of patient. They're multimodal, with many different types of interventions. Perioperative, meaning they not just during surgery or after surgery, but they start before surgery, during surgery, and after surgery. And we use evidence-based So, like I said, it's a multimodal care path that uses evidence-based intervention, and the goal of that is to minimize the stress response to surgery and thereby accelerate recovery. So this is sort of a graph to help us understand what surgery does to a human being. So when you look here at the y-axis, the functional status, meaning the baseline condition, overall condition of a person. When you undergo surgery, surgery is a major stress to the system, and you sort of feel crummy immediately after surgery, and then there's a slow road to recovery. And anyone who's been through surgery knows that there is a recovery phase, that it's not just in the hospital, it continues on after you leave the hospital, and it can take a long time. The goal of enhanced recovery is to make sure that the stress during surgery and in the immediate recovery from surgery is a less pronounced stress, so that you recover quicker and go faster back to the functional status that you were in before you had surgery. And that's really the goal of enhanced recovery, is to minimize the stress response. And the reason for that is because we know that if we can reduce the physiologic stress that's induced by surgery, we reduce complications, we allow people to go home from the hospital faster, and we allow them to get back faster to their preoperative health, including earlier return to work or school or other activities. And also importantly for patients with cancer, to let them go back faster to any type of treatments they might need after surgery, such as chemotherapy. So the concept of enhanced recovery, it wasn't just one person, but really the person credited with pioneering many of these aspects was Dr. Kielet from Denmark. He's a colorectal surgeon in Denmark. And then our own Dr. Delaney, who was an institute chair and one of our colorectal surgeons here, he really was instrumental in also bringing many of these concepts here to the United States. And this is a graph from one of my partners, Dr. Holloway, where he looked at the volume of publications, meaning the research that's been done on this topic over the years. And you can see in the 90s, it wasn't that active in the field, but it has really exploded over the last 20 years, with there being hundreds and hundreds of publications really coming out on enhanced recovery, meaning it's still an active area of research, and there's really many components to it that are still being learned about and that we are innovating in. So what exactly is enhanced recovery, and what is the evidence? So surgery is somewhat different than some of the medical practices, where a lot of what we have been doing in surgery has been driven by things that we are used to doing, and sometimes dogma, meaning beliefs that we were taught sort of from our mentors, that they've been taught from their mentors, that often didn't have a lot of data supporting it. And one of these that is common is fasting. And everyone who's had surgery has known that you're very hungry going into surgery, and we tell people they can't eat anything before surgery, can't drink anything. And there has been some change in that, not only in eating before surgery and drinking before surgery, but also after surgery. And I'll talk about that more. In the past, 10, 20 years ago, all surgery was done with open, big incisions. And we've really moved to, whenever able, do laparoscopic surgery, which leads to smaller incisions and faster recovery. In the past, every patient would get a lot of IV fluids before surgery, during surgery, and after surgery. And we've learned that these IV fluids can be harmful. So we have a more judicious approach to how much fluid we give. Analgesia, meaning pain control. Everything in the past was driven with narcotics or opioids, and we've learned that these are harmful. So we're trying to avoid opioids as much as we can, and instead replace them with other modalities of pain control that I'll talk about more. Bed rest, that used to be after surgery, people thought that you can harm stuff by getting out of bed too early, and we now know, and all our patients know, that we really encourage them to get out of bed as early as possible and walk a lot after surgery, and that helps you recover faster as well. We used to always have drains. We still need them in some conditions, and catheters that go into the bladder after surgery, and we try to get rid of them as fast as possible. A major concept is that it used to be surgery was centered around the surgeon, where the surgeon was sort of driving everything, and all the decisions were made by the surgeon. And now we really have learned that in order for us to accelerate recovery and make sure that the patients do well, that everything really has to revolve about the patient. And the patient has to be involved not only in decisions before surgery, but also be helped understand what is involved in surgery and what is involved in recovery, and have the patient be an active process of that. And that's what part of this talk here today is about, is to make sure that patients really are informed and know what's going on, because that's been shown to really affect outcomes as well. So as I said, it's not just about the intraoperative, what we do during surgery, but to recover from surgery, a lot of it can happen before, during, and after surgery. And I'll talk about these phases in sequence, and we'll start with the preoperative phase. And this is really a time where patients can have a major impact on how they will recover. And there are different parts of the preoperative phase. There's education, and that's part of what we're doing today, but also part of what happens before surgery. We're talking to the surgeons, the nurses, and all the other team members, the anesthesiologists who are involved in it, where the patient can learn a lot about what's going to happen and what they can do to get better faster. And there's a period of optimization where what we can do to improve the preoperative condition. And lastly, preparation, where it's just certain tasks that we should do to avoid complications and to improve outcomes. So education, again, I keep harping on it, and it's just so important. Patient, family, friends, whoever's involved, if you're becoming an active member in the path to recovery, it has a huge impact. Detailed information on what to expect can help alleviate anxiety, and we can prepare for post-operative outcomes. And if the patients know what to expect before, during, and after surgery, that can be huge in terms of alleviating anxiety, but also knowing how to prepare. And our job as care providers is to help patients understand how they can contribute to achieve the best possible outcomes. In terms of what we do for optimization, so there's many different factors. Again, young people who undergo surgery are usually healthier than older people, but every patient before undergoing surgery should have an overall health assessment. Is there any other medical conditions that can affect recovery, such as diabetes, high blood pressure, etc.? We've heard a little bit about how alcohol and smoking can affect cancer, but it also affects recovery from surgery. And I stress that of all my patients who smoke, quitting smoking, or at least reducing significantly the amount of smoking, can have a major impact on recovery from surgery, and also alcohol consumption. Anything that's excessive can really affect your recovery. For those who have diabetes, making sure that your blood sugar is in the right level before surgery is extremely important in terms of preventing infections. Healthy body weight. So both being underweight or overweight can really affect your recovery from surgery. Whenever there is time before surgery to achieve a healthy body weight, that is extremely important. People who have colorectal cancer are at higher risk, or polyps are at higher risk for anemia due to blood loss, and supplementing with iron before surgery, either orally or through the IVs, has been shown to reduce the need for transfusions around the time of surgery and can also help improve outcomes. So these are all interventions or things to focus on before surgery that can optimize your medical condition. A recent focus has been on prehabilitation. We all know what rehabilitation is, and for people who have a sort of complicated recovery, they frequently need to undergo rehab to get back to their pre-surgical state. What there's been a focus on recently has been to see, can we, instead of just focusing on post-operative recovery, can we preemptively prepare for surgery by improving our functional status? And something I tell my patients often is that major surgery is really like running a marathon, and nobody would ever go to a marathon without preparing for the marathon. That would be crazy. We all know that you need to prepare for a marathon. You can't just jump right in it. And it's the same thing for surgery. You want to prepare for it and be in the best possible shape you can be, best possible medical health and fitness for that surgery. And going back to this graph that I showed before in terms of the stress response of surgery and how it affects recovery, you can imagine that if before surgery you can improve your baseline functional status, that will allow you to go back to a good functional status faster and really allow you to be in better condition immediately after surgery. There are many factors in our patients that are risk factors for having a decreased functional capacity before surgery, such as malnutrition, anemia, neoadjuvant therapy that we'll hear about more, anxiety and depression, and frailty. And frailty, what I mean by frailty is usually it's the opposite of being fit. Somebody who's frail is not able to exercise well, is not able to even sometimes walk at a reasonable level. And we don't see that often in young people. We see it more in older people, but even young people, that especially those who are dealing with a medical condition for some time, can be found to be frail. And we recommend exercise training, and there can be different types of exercises. There's aerobic exercise, moderate intensity or high intensity. You can have supervised or unsupervised training. Nowadays with Fitbits and other sort of pedometers, there's a way to have supervised training, so to speak, even without having a coach or a group where you go. So there's different ways of how to work out. The CDC, just in general, for anyone, recommends 150 to 300 minutes of weak or moderate, or 75 to 150 minutes a week of vigorous intensity. So that's for anyone. But really leading into surgery, especially if people are not at that level of fitness to allow for it, even just walking and increasing every day leading up to surgery and to get up to 10,000 steps a day has been shown to really improve outcomes. So working on fitness before surgery can have a significant impact on how you recover. Nutrition is a big factor. We heard from Dr. Cresci before in terms of how it affects cancer development, but it affects your recovery from surgery too. And I won't go into too many details, but high protein is important and balanced meals. Recently, there have been some new nutritional supplements called immunonutrition that have been developed that are thought to boost the immune system before surgery. And if you had surgery here recently, this is something we routinely give our patients after surgery, but people who have issues with nutrition before surgery, this is something you can take 5 days leading into surgery, and it has been shown to potentially reduce the risk of complications after surgery. And there are many different brands of these immunonutrition drinks, and there is some data supporting that they can help recovery and help reduce complications. Psychological issues before surgery can also affect recovery, and anyone who's undergone major surgery knows that this is, this provokes anxiety, and anxiety can affect how you recover. People who deal with anxiety before surgery, we have psychologists, trained psychologists, who are available for visits to discuss surgery, and it's been shown to be helpful in the recovery, help lead into surgery, and this is something that we need to know more about, and that people need to know that this is something that's available for them to meet with a trained psychologist before surgery or after surgery to help with the mental and psychological aspects from recovery. Lastly, just in terms of preparation for surgery, there's a checklist of things that we do for all our patients, medications that you need to take or not take, bowel preparation, obviously. Many of our patients are familiar with those from colonoscopies, skin cleaning and shower. We give preoperative pain medication, antibiotics, and blood thinners. So these are something we do routinely in the day or two leading up to surgery. So moving on then to the intraoperative phase of surgery, what can we do during surgery to accelerate recovery? And really the major change, something I already alluded to, is laparoscopic surgery or minimally invasive surgery, where instead of making a big incision, we make small incisions, use a camera, sometimes use instruments or the robot to assist with surgery to keep the incisions small. And there have been many benefits associated with minimally invasive surgery. There's less pain, there's less of a physiologic stress response, less complications, especially wound infections, faster return of bowel function, meaning faster return of being able to eat, shorter hospital stay, faster return to baseline function, and also better cosmesis in terms of smaller scars. And while laparoscopic surgery is not always possible, especially in people who have had multiple previous surgeries before. Whenever we can do minimally invasive surgery, it's something we always will discuss with our patients and try to do. Another thing we do during surgery or sometimes immediately before or after surgery are nerve blocks. And these help reduce pain after surgery. We can numb the nerves that innervate the abdominal wall. It helps reduce pain and helps reduce the need for opioids. And again, we discussed that opioids are often bad for you. So when we can do something to reduce pain so the patient won't need as many opioids, that's something we always consider. Something we've been doing more in the past and not so much now anymore with laparoscopic surgery is epidurals, which are also very good in helping with pain control. Some other considerations with those, and we use it selectively in people where we are worried about larger incisions and more pain after surgery. So lastly, talking about the postoperative phase. So I talked about walking after surgery. So we know that if you don't walk after surgery, prolonged immobility leads to many different types of complications, weakness, issues with your lungs, with your blood sugar, and blood clots. So we really harp on this after surgery. We educate our patients before and after surgery, and we really want them to get out of bed as soon as possible and walk as much as possible. Our job is also to try to get rid of lines and IVs and monitors as soon as possible, because that helps with getting out of bed. We want people, even on the day of surgery, if they're able to, start moving their legs in bed, dangling them at the side of beds, getting into a chair, starting walking. Whenever patients here in the hospital, we try to record on a whiteboard in the room how often they're getting out of bed, and that's an incentive and a reminder to make sure that people get out of bed after surgery as much as possible. In terms of diet, again, we discussed this before. Often after surgery in the intestinal tract, you're unable to eat immediately after, but we try to encourage people to try eating or drinking at least after surgery if they're not nauseous. And that's been shown to actually help with the GI tract to recover. Obviously, if you're nauseous and you're unable to eat, it's not something that will work. But if you start with small amounts, that's been shown to help the GI tract recover and help, again, with recovery going faster. Again, I can't say enough about that. The opioids, we know they inhibit recovery. So whatever we can do to minimize the need for opioids has been shown to improve outcomes. And we do that by giving other types of medications such as NSAIDs and Tylenol to reduce the need. Gabapentin is another medication we use that can help reduce pain. And sometimes even just numbing patches can help reduce the pain to somewhat. So it's not one thing by itself, but using all these different modalities, including the nerve blocks, has been shown to reduce the needs of opioids. And the less opioids a patient needs, usually the faster they're out of the hospital and the faster they get back to their usual state. Another very important aspect is to know when the patient can go home, and the patient should know that ahead of time and what the factors are that we're looking for. And this is something we give our patients in the hospital. What's the checklist to know when you're close to getting out of the hospital? Tolerating diet, passing gas or having stoma function, pain being controlled, able to walk, have help at home, and have a ride home. So again, some of that is preparation, but some of it is also just reaching those milestones in the recovery. And if you know ahead of time what to expect, then that helps prepare for that as well. Lastly, just to drive this home again, enhanced recovery after surgery, there are many different components to it, and each component by itself might not have that big of an impact, but if you take it all together and all these different modalities we use before, during, and after surgery, when we use them all together as a pathway or as a bundle, and that's when they've shown to be most effective. And we really try to use as many ones and as many of these different components in as all of our patients. And even if a patient for whatever reason can't have all the components, even just using some of them makes a big difference. So thank you, and again, please submit any questions. And we will get to them at the end of this session. So, like I said, surgery is often necessary, and what we've been talking about so far has been how do we, what type of surgery do we need, and how to recover better from surgery. But Dr. Gorgun will be talking about some ways how we can avoid surgery potentially, and he'll be talking about advanced endoscopic methods that can help achieve that. Dr. Gorgun, please.
Thank you very much, Dr. Liska, and thank you for this kind introduction and that extremely well presented talk on enhanced recovery pathways and how we can help our patients when we operate on them. My goal in the next 15 minutes is to talk about how we can avoid operating on our patients, and that so that we don't even have to use these enhanced maybe recovery plans and protocols. Of course, when we need to operate on them, these are extremely beneficial. As Dr. Liska mentioned, I will talk and give more details how we can avoid surgery by using some of the advanced endoscopic techniques, or if you will, like a colonoscopy or gastroscopy type things, or anything that goes through our natural orifices from mouth or from anus with flexible scope, and deal with the problem, whatever the problem is. Obviously, in these circumstances, in the colon, especially, what we're talking about is more polyps or early cancers, and can we do some procedures to avoid unnecessary surgeries? These are my disclosures. We all heard that also part of this center is now focused, one of the focuses is to young onset colorectal cancer. Indeed, when we look at the last several decades, the black bars are the annual percentage changes in colorectal cancer in patients between 20 and 49. As you see, there is a change in terms of increasing in the last 3 decades of colorectal cancer in this age group versus in patients older than 50 years old. You can see at the bottom of the graph, gray bar, the cancer is actually relatively lower than the increase in the and then the younger generation. And we all heard about the risk factors. I'm not going to go into that. Certainly, low fiber diet, more alcohol, smoking, and inactive lifestyle. We all heard about those, and these are important things to avoid. But no matter what we do, and even if we obey the rules religiously, we may still get polyps or cancers, and that's where the screening colonoscopies come into place, just to observe, watch inside lining of our colon to make sure that there's no precancerous lesions that are trying to come up and then down the road turn into cancer. So my talk will focus on how we can find these small polyps first, and then how can we remove them. We also heard that the U.S. task force recently published the recommendation to be screening starting at 45. But more than that, also any individual under age of 45 who has rectal bleeding or strong family history or anemia or even unexplained abdominal pain, those patients are qualified to have a colonoscopy. So when these things are done, we certainly get some patients that have found something like this on the screen. This is a polyp. This is an abnormal tissue within our colorectal lining of our intestine. So anyone can appreciate this abnormal structure here. So we know that more screenings are occurring and fewer cancers are found, but more polyps like this are identified. And we also know that 1 in 6 Americans will form an adenoma. That's another term for polyps. And then these can be and has to be removed. And we also now know that there's a rise of polyps in young patients as well. So especially with symptomatic patients or not symptomatic patients with the screening colonoscopies, there are polyps that can be identified in younger group of patients. And we know that mean age in younger group of patients are 41.9. So it does occur, and it's a reality. It's a fact that as young patients or people, polyp is also a problem. And we also know that polyps, removing these polyps from the colon does decrease the incidence of colorectal cancer. Why? Because we prevent these polyps or abnormal tissues progressing to a cancer state. Majority of these polyps can be easily removed with just like a lasso or a wire around it, endoscopically through colonoscopy. But up to 15% of polyps will require more advanced techniques. And we're gonna talk more about what these advanced techniques are. There's always gonna be a surgeon available there to remove these polyps, but and they will do that. And you will be recommended as patients when even a polyp is found to have surgery done. But this is not really necessarily always the best approach. There are polyp removal techniques. What are those? Like mentioned a little bit before, like using a lasso or a round wire that we can bring through our endoscopy channels inside of the colon, intestine, and remove these nasty guys or gals. And the technique we use is that we just open the wire, we push down on that abnormal tissue, on that polyp or the area that looks like a mushroom, and remove it and close that wire like a lasso and snare it in chunks. We do have different snare techniques for that, or snare shapes, like it can be round, hexagonal or oval type snares, and we can remove them. But like mentioned, some of them are not able to be removed with these simple wires or round shaped snares, we call them. So in these circumstances, what we do is we use advanced endoscopy or more advanced technique. We like to call these techniques more recently endoluminal surgery, basically going through the anus with a flexible instrument, with a flexible scope, which also has a tiny bit of a channel where we can put in some instruments, special knives like you see on this picture, and do these operations intraluminally inside of the intestine. What we also do before we cut, we inject, we infiltrate underneath the polyp with some special solutions, fluids, that lifts up the lesion, and that gives a cushion underneath the colon wall or colon underneath that polyp. And then subsequently we make our cuttings like you see in this D picture with these special knives that we use, and ultimately remove the lesion. How does this look like in real life? This is, for example, a patient of ours who was a 52-year-old young woman, originally from Iceland. She was a very good chef in Iceland and married an American person and moved to this country, and was on screening colonoscopy. Thankfully, to the screening colonoscopy was found this lesion. As you can appreciate, this is certainly a raised lesion. Looks a little bit suspicious, and we have options. We may even do, and to be truth to be told, nationwide in the United States, most of the time these patients are referred to a surgeon. And I need to disclose here, I'm a surgeon as well, and I do these operations, but there is a role for advanced endoscopy in these circumstances. But nationwide, I can just tell you that most of these patients with a polyp that you have seen are referred for bowel removal and major surgery, or we may remove these polyps in a piecemeal fashion, or perform these in a more advanced endoscopy, which I explained a little bit earlier, with an endoluminal surgery, which is kind of like this, like we said, putting little injectate, little fluid under the lesion, and making these precise cuttings around the lesion with clear margins, with safety borders, and completely irrigating, taking it out and removing it like an end block, and getting specimens like this. This is why we like to call this endoluminal surgery, because we literally doing inside of the intestine advanced surgical procedures, but that allows us to safely remove these lesions. And even if there is a small focus of cancer, we can certainly identify that and safely make plans for further treatment options, which most of the time most patients get to keep their colons intact, so the colons do not need to be removed. This is an interesting study. The incidence of polyps and the surgeries for polyps in the United States has increased during the last 10-15 years. So there are more and more patients undergoing colon removals for benign polyps, but less and less for cancer. And that's, I make the analogy like for a benign breast cyst, almost removing the entire breast for a benign fibrocystic lesion or something like that, for a benign cystic lesion. So that's an overkill. So there are options that we can do, like advanced endoscopy, as we discussed earlier. And when we look also in the United States, there are between different states, how much colons are removed for benign polyps is different. There are between states even up to 70-fold difference. One state may take colons for benign polyps more often than others. And what is found is that there is limited advanced endoscopists. There's limited access to advanced endoscopists, not many centers where these type of services, advanced endoscopic services, are provided. So this is a significant reason for that, and our goal of our center is to avoid these unnecessary colon resections, and also make sure that there are many other centers in the United States and in the world to prevent people and humankind from having unnecessary organ loss, meaning in this case, obviously, or colon and rectum. Therefore, we have these different techniques and the luminal surgical techniques as listed: EMR, EST, which I'm not going to spend too much time on that. But basically, advanced removal of these polyps are certainly possible. We went through this. Getting these polyps out is possible. We use different knives, different tools, and technology is advancing very quickly, and we are able to use and utilize these in our practices. However, these techniques are really not easy. That's part of the reason why there are not many centers. That's part of the reason why there are not many advanced endoscopic proceduralist surgeons or gastroenterologists available. And it's also, to some degree, difficult to perform. If you think about it, you have as a surgeon, you have two hands to operate, but when you try to operate this through the endoscope, you are almost like a rhinoceros. One hand tied behind, and you're trying to do that with your nose and dig in. That's why we have new techniques, new platforms to make these endoluminal surgery more possible, more practical. What do we have? There are newer platforms enabling us to do where we can bring a different platform over the scope, or graspers, retractors, we can bring them in, or even robots, med-robotic or endorobotic platforms we can bring, even to the point that we have almost joystick type of instruments that we can remove these lesions. This is how things look inside of the intestine, and perioperative care and setup, and how we take care of our patients. But at the end, we are also physicians. We get sick. We have lives outside here as well, and we sometimes do crazy things. And that's what gives us the joy, even taking out something like this endoscopically completely, and removing these lesions and sending these patients home same day. And this is really magnificent outcome for our patients, and that's really the most rewarding thing that we receive when we feel when we really can provide this type of a help to our patients. So back to these enabling technologies, for example, this is one of the instruments that enables endoluminal surgery, double balloon system with graspers and retractors. Here we can see Dr. Liska briefly mentioned about laparoscopy. This almost looks like a laparoscopic surgery, if you will. We place these platforms, balloons, instruments go in through the external channels, and then we operate. And therefore, we like to call this type of approaches endoluminal surgery. When we come across vessels, we can prophylactically tie them off, buzz them off, and prevent unnecessary bleedings, and ultimately really remove these lesions successfully, and patients go home again same day without any problems. So that's amazing. This is another similar lesion all the way in the colon, in the cecum, so we can really reach even through the anus, deep inside of our intestines, bring instruments, do retractions, contractions, and do these operations successfully. And the last patient that I showed was this one. So we have done many patients like this with using these endoluminal robotic procedures, but to be able to develop this endoluminal approach, certainly innovation and technology needs to be there, and that will certainly come and follow these procedures. But as physicians, we like to also ride the right wave of the innovation in order with the goal of saving the colon. So if we use and utilize these innovative techniques and approaches with the safety, of course, we will be able to save more colons for our patients and prevent unnecessary bowel resections. And lastly, I like to talk about a little bit more towards future inside of the colon. Here you can see from anus, these instruments are entered into the rectum, into our colon, intestine, and we are removing these complex polyps very easily with the help of a robot. These are robots, the instruments that are in development. This is more like a semi-flexible platform, but as time goes and the time investment in innovative and research and development is applied, these techniques and approaches and will undoubtedly develop and get us to better positions, to the point that we can easily remove these lesions, even up in the colon, within a matter of minutes, and very quickly and safely. And even if there is a rupture deep in the colon, we can suture them and close them. So our experience has been incredibly fast. We started our endoluminal surgical practices about 10 years ago, and we are up to getting closer to 1,000 patients right now. We have done many colon preserving and organ preserving procedures and avoided unnecessary colon removals for our patients. Of course, we know where to stop. When we find more advanced cancers, then of course an oncological resection is required and needed. But that puts us also as surgeons and being a multidisciplinary center in a good position, because we can really make the right decision for our patients and provide them the right treatment. Recently, I'm privileged and honored to be able to build this endoluminal surgery center with my colleagues from gastroenterology, who is specialized in endoluminal procedures for the upper gastrointestinal system, especially stomach and duodenum and upper small bowel, and Dr. Amit Bhatt. So we have been doing terrific developments and research, collaboration, and patient care. And he's certainly part of our endoluminal surgery center, as well as the Vice Center and Hereditary Colorectal Cancer Center as well. So in conclusion, I like to emphasize that endoluminal surgery and organ preservation is extremely important, and screening and polyp identification gives us the ability to remove the lesions endoscopically, with advanced endoscopically and endoluminally, and help our patients to preserve their organs, organ sparing approach, and save their colons. My last take home recommendation could be that, you know, when our patients or family members are told to oh, you got to have your colon removed. You got to have, there's only way to this polyp or lesion needs to can be treated is by taking your colon out, is just research, or advise them that, hey, ask for a second opinion. There might be other alternatives, endoluminal operations, or advanced endoscopic techniques are available. Especially, certainly, they are at our center here at the Cleveland Clinic. I thank you for your attention.
Thank you very much, Dr. Gorgun. This was really terrific, and you make it really look easy on some of these videos. And I know that it's not easy, and we're incredibly fortunate to have someone like Dr. Gorgun with his expertise and experience here for our patients with the endoluminal surgery center, so we can really try to avoid surgery whenever we can and do it in a safe fashion and in really expert fashion with really unparalleled experience that we have here with Dr. Gorgun and Dr. Bhatt. So thank you so much. And speaking of experts, moving on to our next talk, then Dr. Krishnamurthi, one of our oncologists here, seeing many of our patients with colorectal cancer, also very interested in young onset colorectal cancer. Dr. Krishnamurthi is also involved in writing the national guidelines for colorectal cancer treatment. So again, thank you so much for joining us today and talking about when chemotherapy and radiation are needed.
Thank you, David. So I'm a medical oncologist, so my role is treating patients with colorectal cancer with drug therapy, mostly chemotherapy, but also immunotherapy. I'll be talking today about when chemotherapy and radiation therapy are needed. There we go. This is my disclosure. And I just want to clarify some terminology. When we use the word adjuvant, that's referring to chemotherapy we give after surgery. So colorectal cancer is cured with surgery, but chemotherapy can increase the cure rate if we give it afterwards to kill any microscopic disease, like cancer cells that got into the bloodstream. We use the term neoadjuvant when we give chemotherapy before surgery to try to maximally shrink the tumor before surgery so it can be completely removed, and also to start treating any of that microscopic disease that may be getting into the bloodstream, so trying to prevent spread. Again, just trying to help increase the cure rate. Concurrent chemoradiation refers to chemotherapy given simultaneously with radiation. So we're treating the cancer, we're trying to make the cancer more sensitive to the radiation. And then palliative chemotherapy refers to when we're using chemotherapy in a non-curable situation where we're trying to help people live as long as possible and reduce their symptoms or delay when they have symptoms from their cancer. So I'm going to launch into treating colon cancer, and for stage 1, thankfully, those cancers are highly curable with over 90% cure rate. So I don't meet patients who have stage 1 disease because they don't need chemotherapy. And this is the same picture Dr. Sommovilla had shown about the staging. And as we just saw from Dr. Gorgun's beautiful videos, these cancers start on the inside of the colon and rectum and then grow through the colon wall. And when we have a stage 2 cancer, it does not spread to any lymph nodes, but it may be going to, if you can see my arrow, this subserosa, that's T3, or serosa, the outer layer, which is T4. It may also have grown right through the wall and be invading another structure, that's T4B. So then we have these categories, stage 2A, B, and C, reflecting that. And when we refer to high-risk stage 2, those are T4 tumors, or tumors that have perforated or caused an obstruction, or there's cancer cells in channels on their way to lymph nodes or blood vessels, or if fewer than 12 lymph nodes were identified in the surgical specimen, because that always makes us concerned that maybe this is really a stage 3 or a lymph node positive cancer. So for somebody who has stage 2 colon cancer, we don't have great evidence that chemotherapy improves survival. The biggest study was an old British study called the Quasar study with almost 3,000 patients enrolled after surgery. They were randomly assigned to observation or chemotherapy with 5-FU and leucovorin. And what you can see here is on the graph here, the recurrence rate. This is the blue dots are the patients who had observation, the green line are the patients who had chemotherapy. And so there was a small reduction in recurrence with the chemotherapy, and the lower curves are survival. So the patients in green had the chemotherapy, they had a small survival advantage. It was actually 3.6% improvement at 5 years. So our national guidelines recommend that for patients with stage 2 colon cancer, that they see an oncologist to have a discussion about chemotherapy, but that the survival benefit is probably 5% or less. Looking at high-risk stage 2, we have a study called the IDEA trial, which took patients who had high-risk stage 2 disease and randomly assigned them to doublet chemotherapy, 5-FU plus oxaliplatin, called FOLFOX, or a pill form of 5-FU, capecitabine and oxaliplatin, called CAPOX. And the randomization was to 3 months or 6 months of treatment, because 3 months of therapy is less toxic. We get less nerve damage from oxaliplatin or neuropathy. And what this study found was that the disease-free survival at 3 years was pretty good with the capecitabine oxaliplatin at 85%. With just 3 months of therapy. And for CAPOX, there was no difference between 3 months or 6 months. We didn't get any better results with 6 months. So 3 months of CAPOX is an acceptable treatment for patients with high-risk stage 2 disease. With FOLFOX, it was a little bit different. There was a 2.6% improvement in disease-free survival with 6 months. So we've learned from the IDEA study that these regimens are actually not quite interchangeable, and CAPOX performs better in the 3-month setting. We have this study open here at Cleveland Clinic. It's a national study that's through the cooperative groups. It's known as a COBRA trial. It's looking at circulating tumor DNA to guide therapy for stage 2 disease. So like, how can we become smarter about identifying who really needs treatment and who will benefit from treatment? So for patients who have stage 2 colon cancer, low risk disease, where physician feels comfortable with no chemotherapy, the randomization is to arm 1, standard of care, surveillance, but blood is collected for circulating tumor DNA, but the testing will be done at a later point in time. Arm 2, patients have a blood drawn for circulating tumor DNA, and then if circulating tumor DNA is detected, they are treated with 6 months of FOLFOX or CAPOX, and if there's no circulating tumor DNA, they're followed with active surveillance. So this is an excellent study that, you know, some years from now will give us some definitive answers about this approach. Okay. Trying to advance my slide. There we go. What about patients who have defective or deficient mismatch repair, which is also referred to as having high microsatellite instability? So in the young population, this would primarily be patients who have Lynch syndrome, but this can also occur sporadically, so it doesn't have to be an inherited condition. This is some very old data published in 2003 that shows us that these patients have very low risk of recurrence, that is having stage 2 colon cancer with deficient DNA mismatch repair. So what we're seeing here in the graph, patients who had the deficient mismatch repair or microsatellite high tumors versus those who have microsatellite stable tumors. And none of these patients had chemotherapy. And you can see that the microsatellite high group had a much better survival. This study also found that treating these stage 2 patients with adjuvant 5-FU resulted in worse survival for the patients who had deficient mismatch repair. So there's no role for adjuvant therapy for stage 2 colon cancer that has deficient mismatch repair. Okay, what about moving on to stage 3? Stage 3 is when we have the cancer spread to lymph nodes but has not spread distantly. And this is a very old study that established 5-FU as a standard treatment for patients with stage 3 colon cancer. It was given with levamisole, which is a drug that we now know has no activity. But this study showed, and this is looking at recurrence, living without a recurrence. The top line are the patients who had the 5-FU and levamisole, and the lower lines are those who had observation or levamisole only. So there's a clear separation of the curves, and it's maintained going out to 9 years. So definitely this chemotherapy is resulting in cures in patients who have stage 3 disease. And this is the same study looking at the survival curves. So definitely a survival advantage for 5-FU chemotherapy for stage 3 colon cancer. But as we mentioned, we have a more active regimen called FOLFOX, which is 5-FU plus oxaliplatin. And that has become standard of care for patients with stage 3 colon cancer based on this French study called the Mosaic trial, where they randomly assigned patients with stage 2 and stage 3 colon cancer to infusion of 5-FU plus leucovorin, a vitamin that helps 5-FU work better, versus 5-FU, leucovorin, and oxaliplatin, which is Folfox. And the treatment was for 6 months. And this study found no benefit among all comers with stage 2 disease, but among stage 3 patients, a 4% increase in survival. So that is now our most active regimen for stage 3 colon cancer. And then, what about patients who have deficient mismatch repair? We know that in stage 2, there's no role for chemotherapy, and we know that 5-FU is actually detrimental. But what about Folfox? In the same study, they had 95 patients. It was a very small subset of the overall population, but 95 had deficient mismatch repair cancers, and they had a much improved disease-free survival and overall survival with the Folfox versus 5-FU, as you can see here. And so Folfox is active in these patients, and it is the standard of care, regardless of mismatch repair status. This IDEA study that I mentioned was looking to see if stage 3 patients also, we talked about stage 2, but in stage 3, can we use 3 months of treatment instead of 6 months in attempt to decrease neuropathy? And so they found that yes, neuropathy was significantly reduced. Severe neuropathy was 3% in patients who received 3 months of treatment, as opposed to 9 to 16% with 6 months of Kbox or Folfox. And just this past weekend at our national ASCO meeting, there was an update from this IDEA study, which is shown in this graph here to the right, which found that alarmingly, our young patients below the age of 50 have a higher risk of recurrence with chemotherapy compared to patients who are 50 and older. And so the blue line here is looking at cancer-specific mortality, and this is in the younger than age 50 group. This study also found that our younger patients have significantly more severe nausea and vomiting, so they warrant more aggressive pre-medication to prevent nausea. Here we look at the overall findings from the IDEA study, which is again asking the question, can we use 3 months of treatment for some of our patients with stage 3 disease? And they separated the stage 3 into the low risk group who had not so deep tumors and up to 3 lymph nodes positive, versus the high risk group, which has T4 tumors, so involving that outer layer, or 4 or more lymph nodes. And what you can see here, these curves, this is looking at Folfox. Low risk, really no significant difference with 3 months versus 6 months. With Kbox, surprisingly, the 3-month group actually performed better, which we really don't have a great explanation for that. And this met the criteria for 3 months, was not inferior to 6 months. Technically, the Folfox didn't meet that statistically significant criteria, but you can see just looking at the curves that they're both fairly equivalent. We're looking at the high-risk group. 3 months of Kbox resulted in a 1% drop in overall survival, and the investigator presenting this data felt that that was okay. I don't like to even lose that 1%. So for my high-risk patients, I do treat with 6 months of treatment. And when we're using Folfox, we definitely need 6 months in the high-risk group because they had a drop of 2.8% survival with 3 months. Moving on to rectal cancer, like for colon cancer, when it's stage 1, it's highly curable, so we don't need chemotherapy. Those patients are treated with surgery only. With stage 2 and 3, a difference in rectal cancer versus colon cancer is that we do use radiation because these patients have a higher risk of the cancer coming back locally. These cancers are occurring in the pelvis, and it's a tight space, and surgeons can't remove a lot of bowel on either side of the tumor. And so radiation is very useful in preventing the cancer from coming back where it started. Ionizing radiation are very high energy beams that can either directly damage the tumor DNA, but more commonly, they react with the water in our cells and create oxygen-free radicals, which then attack the DNA. And with enough damage to the tumor's genetic material, the DNA, the cancer cells will undergo programmed cell death or apoptosis. We use either chemotherapy with long course radiation. It's 5-FU or capecitabine to sensitize the cancer to the radiation. This occurs over 5 weeks. Or there's a short course radiation, which is gaining traction here. It's given over 5 days. And we don't use chemotherapy with that. And here I have a schema of what we call total neoadjuvant therapy. So it's now recognized that there are advantages to giving all of our treatment upfront before surgery. So one could start with 4 months of chemotherapy, then the radiation, chemoradiation or short course, then surgery, total mesorectal excision, and then for patients who are not having a permanent colostomy, they will have a temporary diverting loop ileostomy, and then later on they go on to have that closed. Or start with chemoradiation or short course, then the chemotherapy. So just can reverse the order, then go on to surgery. And so what's the advantage of giving this radiation first? We know this from an old study. The German rectal cancer trial showed that giving the chemoradiation before surgery results in a decreased risk of the cancer coming back locally and also decreased toxicity compared to giving it after surgery. And then more recent studies, the Rapido and Prodige 23 trials found that giving the chemotherapy before surgery resulted in a lower risk of metastatic disease at 3 years, 7% risk reduction in both studies. And another trial, the Oprah trial, actually looked at this comparison, chemo first or chemoradiation first. And with patients started chemoradiation first, more patients will have the tumor completely disappear on MRI, on rectal exam, on endoscopy. And so those patients may actually become candidates to avoid surgery and be followed with close surveillance. So that is our approach here at Cleveland Clinic, is we start with the chemoradiation and then go on to chemo before surgery. Just one slide on our metastatic treatment. So this is when the cancer is metastasized or has spread to distant sites like liver or lung. In this setting, if it's beyond the point of surgery, because some colorectal cancer patients can have surgery if it's limited spread to liver or lung or both. But if it's beyond that, then we're using chemotherapy to help patients live longer and to maintain quality of life. And I highlight this, we have several regimens, but I'm highlighting FOLFOXIRI because this is a combination of 5-FU oxaliplatin and irinotecan, which has been found to be more active than doublets like 5-FU and oxaliplatin FOLFOX or FOLFIRI, 5-FU irinotecan. And it's more toxic though, because it's 3 drugs and it's not for everyone, but our younger patients tend to be healthier and fitter and more likely to be a candidate for this treatment. So here we're looking at this graph, survival of patients who receive FOLFOXIRI as their initial treatment compared to starting with FOLFOX and then switching to FOLFIRI, so sequential treatment. And this Italian study found improved survival with starting off with FOLFOXIRI. It was on average a 5-month increase in survival. So I always like to think about FOLFOXIRI for patients who are well enough to tolerate that. We also have drugs that target the blood supply of tumors. These are anti-angiogenesis drugs. Most commonly, it's bevacizumab or Avastin that we use. We have another biologic drug category. These are antibodies that target the epidermal growth factor receptor. We have 2 drugs in that category. These all add to improved survival for our patients. In the metastatic setting, we use radiation for symptom relief, targeted therapy, because radiation only treats where it's aimed, and we're talking about a patient who has widespread disease. So we use radiation where needed. For example, if there's a bone lesion that's causing a lot of pain or pressing on the spine, radiation is very effective. And I want to mention immunotherapy because for our patients, particularly Lynch syndrome patients who have metastatic colorectal cancer that has deficient mismatch repair, or this can also occur through a non-inherited mechanism. Those patients we need to recognize right after their diagnosis of metastatic disease because they do best with immunotherapy compared to chemotherapy. And so this is a study of pembrolizumab, which is immunotherapy, anti-PD-1 antibody, compared to chemo. And here you're seeing the teal line here, the patients who got the immunotherapy, and the maroon is those who got chemo. And starting with immunotherapy resulted in significantly improved progression-free survival, median 16.5 months versus 8.2 months for the chemotherapy. And we saw this past weekend at ASCO also improves overall survival. At 3 years, it was 61%. alive versus 50%. So it's important to recognize that and treat early with immunotherapy for those patients. And so my key points, we got stage 1 disease, patients are treated successfully with surgery only. For stage 2 colon cancer, if it's low risk, we can do observation or 5-FU, capecitabine, or we have the study open nationally, NRG-GI005. High risk stage 2, one could use observation or 3 months of Kbox. And for patients who have deficient mismatch repair stage 2 disease, observation is all we need. Stage 3 colon cancer, low risk, I go with 3 months of Kbox. High risk patients use 6 months of treatment. It could be FOLFOX or Kbox. I prefer 6 months. Stage 2 and 3 rectal cancer, our style here of treatment is chemoradiation, followed by 4 months of FOLFOX or Kbox, and then surgery or watch and wait for those patients when it's appropriate if the tumor has completely gone away. And then for stage 4 disease, chemotherapy improves survival and symptoms. We use radiation to relieve symptoms, and we use immunotherapy as first-line treatment when the cancer has deficient mismatch repair.
Thank you so much, Smitha. This was great, excellent overview and very detailed in terms of factors that go into chemotherapy and radiation. So, Dr. Sommovilla, there was one question regarding desmoids that one of the patients here brought up. And I know that that's something that you did some research on in terms of how the risk for desmoids should affect the decision on what type of surgery we would recommend in FAP. And can you tell us a little bit more about sort of what are the things you consider when you see a patient with FAP in terms of the risk for desmoids and what type of surgery you would offer?
Yeah, thanks. So we've known for a while that there are certain patient factors that put them at risk for desmoid formation in people with FAP. And those things include a family history of desmoid tumors. Women tend to be more likely to form them than men, although men certainly form them as well. Having a mutation at a certain location on the APC gene on the genetic testing, and then having some of the extra intestinal features of FAP all kind of create the increased risk for desmoid formation. So in patients that we know before surgery are more likely to form desmoids in the future, we've also found that doing the J-pouch surgery is another factor that might increase desmoid risk, and that the combination of having desmoids with a J-pouch could make the desmoids potentially more consequential too. So those are patients that we might think before doing surgery that if there's possibility of preserving the rectum and doing a total colectomy with ileorectal anastomosis, that it might help decrease the risk of desmoid formation in the future, or even if they might ultimately need their rectum taken out in the future, we might be able to delay it for a number of years.
Great, great. Thank you so much. Yeah, no, this is a paper that's about to be published from data we reviewed from our patients here at the Weiss Center, where we found, that besides focusing obviously on risk reducing surgery in terms of making sure they don't develop cancer, we also really need to take into consideration desmoids and quality of life implications. That's something we think about all the time. So thanks, Josh, for that. Dr. Krishnamurthi, you briefly mentioned immunotherapy. Going back to our patients, hereditary patients with Lynch syndrome, when is immunotherapy an option for them? Is it only for metastatic, or can they sometimes get it also in different settings?
Yeah, thanks for bringing that up, David. And I think for time limitations, I hadn't included, we have our study, of course, for patients who have rectal cancer that has abnormal mismatch repair, in which patients are getting standard chemoradiation with pembrolizumab, which is immunotherapy. And there are case reports out there of using immunotherapy early for patients with rectal cancer, early stage, that have abnormal mismatch repair, showing that the tumor can completely disappear. And we have observed that on this study as well. And so we are definitely looking for those rare patients who have Lynch syndrome and rectal cancer to offer them this treatment.
Great, thank you. Yeah, absolutely. So yeah, this is a study that we are looking to contribute to our experience with this in terms of how we can use immunotherapy in patients with Lynch, especially in more ways than just when they're metastatic. Going sort of in the same theme, Dr. Gorgun, we're talking about advanced endoscopic methods of removing polyps, and that sounds very nice when it's a single polyp. What about patients with FAP where you have lots of polyps? Do you have any experience in doing advanced endoscopic methods in FAP patients?
Sure. Yeah. FAP, of course, is, as we know, by certain age, there's a high risk for developing colorectal cancer. So certainly genotype and phenotype determines and dictates what treatment they should, our patients should be offered. And most of the time, as you know, is in the form of colocolectomy or proctocolectomy is what's offered. But as also we socialize and advertise extensively also with our former colleague, Dr. James Church, with his incredible contribution to the field, we do know that colocolectomy with IRA, even in patients with FAP, in selected circumstances, of course, as long as rectum is preserved or not heavily involved with polyps, is a very good, valid option, and especially from quality of life perspective. And we have a large number of patients that we follow very closely. And especially in these patients, when we monitor and survey the rectum, when there are polyps identified, and they may be some patients that are reaching a little bit more advanced age, certainly proctectomy does not sound very good. And in this group of patients is a very valid option in FAP.
Great, perfect. Thanks so much. So in the interest of time, I think we'll stop here with this session, give people just a 5-minute break. But moving along, so the first session, we heard a little bit about what causes cancer and risk factors for cancer. Then we spoke about treatments of cancer and how we can modify treatments and improve outcomes. And the next session now is about considerations for survivors of colorectal cancer. Again, our goal is obviously for patients who have cancer to be cured of the cancer, for patients who have hereditary conditions to either never develop cancer or again be cured from any type of cancer. But that's not where it ends. And as you all know, that after surgery, after chemotherapy, there's still an active surveillance phase. And for hereditary patients, these are relationships we have with our patients for the rest of their lives, and they're considerations that go along even after the cancer is long gone. So this is what our next session is going to be about, and Dr. Carol Macaron is going to be moderating this session. Dr. Macaron is one of our gastroenterologists here with a special interest in both young-onset and hereditary colorectal conditions. Many of our patients already know her, and she trained here as well. And thank you so much for running this, Carol, and please go ahead.
Thank you for having me. So as Dr. Liska said, this section, the last section, will cover, will actually target young patients who survived colon cancer. There are a lot of considerations that come along, starting from fertility preservation to navigating life detours, strategies to cope with their cancer diagnosis, and most importantly, surveillance that will have to follow, as well as screening for family relatives. So starting off, I would like to introduce our first speakers, Dr. Detti and Dr. Leach. They will go over fertility preservations and sexual health for both men and women with colorectal cancer. Dr. Detti is the department chair of subspecialty care for women's health. Please, Dr. Detti, the stage is yours. Go ahead.
Hi, Dr. Macaron, thank you so much. I'm very honored to be here. Thank you so much for the invitation, Dr. Liska and Dr. Steele. And I'm Laura Detti, and I will be talking about options for fertility preservation in young-onset colorectal cancer patients. I am also the director of the fertility preservation program at the Cleveland Clinic. And we've been we've been trying to expand our reach to all patients. So I truly appreciate what Dr. Liska has done in the past to incorporate fertility preservation into the colorectal cancer treatment. So in the beginning, I will just give you an overview of the physiology of reproduction, and then we will go over on the techniques that we use nowadays to allow patients with cancer to have fertility preservation. So I will cover the female part, and Dr. Vij will cover the male part. So in the female, what we know is that the number of oocytes is finite. So females are born with a fixed number of oocytes that are organized in follicles that can be seen here in this picture of the ovarian cortex. Which shows all the development of the ovarian follicles. So the number of oocytes is maximum when the female is in utero still, so at around 20 weeks gestation. By the time a female fetus is born, her number of oocytes and follicles is already decreased by over half. And you can possibly see it here in the graph to the left-hand side that at birth is about 2 million that reservoir of the ovaries. At puberty, that number is further decreased to about 400,000. And of course, they only decrease gradually throughout a woman's lifetime until she goes into menopause, which is approximately around age 51 as an average. So what happens whenever we give an insult to the ovaries? So that number of follicles will only decrease, as we said. It will never be regenerated. So any chemotherapy or radiotherapy can cause ovarian damage. And the alkylating agents are the most deleterious ones that will cause ovarian damage. In these two sections of the ovarian cortex, you can see two different stainings of the same follicles after chemotherapy. So if an H&E stain will not really give you an idea of whether the follicles are really still viable or not in the ovary, when we use the tunnel immunostaining, you can actually see that the nuclei of the apoptotic cells or necrotic cells are stained in a brown color. And as you can see in this picture to the right-hand side, there are many nuclei that are unfortunately stained with the brown color, noticing, of course, the apoptosis. So looking into a little more detail, what radiotherapy causes is a damage of all cells, and this damage entails all levels of follicular development, from the primordial follicles, which are the main reservoir. This is the maximum number of follicles that are in a female's ovary, to the primary and then secondary and eventually the tertiary follicles. So at all levels, we will have damage. When we look at the damage caused by chemotherapy instead, we see that the primordial follicles, so the main reservoir again, is spared by chemotherapy. And that is because, as we all know, chemotherapy attacks fast reproducing cells, especially the alkylating agents. And so the primordial cells instead are quiescent. They're metabolically inactive, even the granulosa cells surrounding the egg. And so they can be more chemoresistant unless they're very close to a blood vessel, and chemotherapy, of course, can attack those directly. But typically, they're very well protected. So what happens when we do chemotherapy, though? What is the mechanism by which we have this destruction of the follicles and so a decreased ovarian reserve? Well, there are different theories, of course, but this is possibly the most plausible nowadays. And what we can see in this slide is the different developmental stages of the follicles and their hormonal control. So we have this AMH, which is the anti-Mullerian hormone, which is an inhibitory hormone on the granulosa cells. So it prevents them from replicating, and it prevents the primordial follicles from entering that first developmental stage that will bring them to become primary follicle that can be attacked and, of course, destroyed by chemotherapy. So in attacking mostly the bigger follicles, like the secondary and tertiary follicles that produce this AMH hormone, chemotherapy will decrease the amount of AMH that is in the ovary, and hence more primordial follicles will enter that first developmental stage, and they will then burn out because the rapidly replicating granulosa cells will be under the effect of chemotherapy and they will die. And so that what will happen is that over time, with more and more cycles of follicular development, the ovarian reserve will progressively decrease. So AMH will be the hormone that that is used nowadays to measure the ovarian reserve before and after a chemotherapy. And unfortunately, as Dr. Krishnamurthi was saying before, until we start using more and more immunotherapy, this is what we would normally deal with. So with this very nice work of Dr. Su out of the University of California in San Diego, what she delineated was the trajectory, the downward trajectory of AMH after chemotherapy. So they followed a very big number of cancer patients who were treated with chemotherapy, and they divided the chemotherapy into a low toxicity, a moderate toxicity, and a high toxicity for the gonads. And what she found was that when we use low or moderately gonadotoxic treatments, the AMH levels after an initial decline, it will re-increase over the following 2-3 years, and then it will plateau for about 10-15 years. But then it will invariably decline. So if you give chemotherapy, for instance, to a 10-year-old, you would expect that she could go into more infertility and then eventually menopause by the time she's 30 years old. With high gonadotoxic treatments, instead, the AMH levels are unfortunately decline shortly after peaking at 2 or 3 years after that treatment. And so you could expect, again, in the same young female of 10 years old, that by the time she is 15 or 16, she might not have any more ovarian reserve. And what was found was also that a younger age was not really protecting whenever we used highly gonadotoxic treatments. So the general outcome of women undergoing chemotherapy is that with alkylating agents, as we said before, especially cyclophosphamide, busulfan, and others, they're considered the most deleterious for the gonads, and the extent of the damage is dose dependent. Cancer treatment causes primary ovarian insufficiency, which is the complete loss of all the follicles from the ovaries in 10 to 25% of prepubertal patients and in 36% of postmenarcheal patients. In addition, radiotherapy causes POI, this primary ovarian insufficiency, with just 5 to 20 grays, and less than 2 grays to the gonads can still destroy 50% of the oocyte reserve. In addition to the ovarian damage, radiotherapy also causes uterine damage, and that can hamper the final uterine volume and hence the ability to carry a pregnancy, even if the woman would like to have and carry her own pregnancy. So the probability of having a live birth in cancer survivors is 30 to 50% reduced when it is compared with control subjects, which are mostly in these studies were the siblings. And the potential for infertility is the considerable source of distress for patients with cancer. And there is a strong desire among survivors to have their own biologic offsprings. So having fertility is actually very important for survivorship, and so we need to do something to prevent this decreased ovarian reserve or primary ovarian insufficiency. And there's 3 options basically for female patients. One is using the GnRH analogs. The second is to do oocyte or embryo cryopreservation. And the third is to do ovarian tissue cryopreservation, which is the youngest of these techniques. And we will go over each one of them in a little more detail, but briefly. So the GnRH analogs have been hypothesized to work in 5 theoretical mechanisms. And then with our studies, we also added a 6th possible cause for protection of the ovaries. So the first one would be simulating the prepubertal hypogonadotropic milieu. So the ovaries are not stimulated any longer by the follicle stimulating hormone that comes from the pituitary. And hence, being quiescent, those granulosal cells will not replicate so fast, and they should be protected from chemotherapy action. Then direct effect on GnRH receptors in the ovaries, which is something that has not been really proven yet. Decreased ovarian perfusion, that has been studied, but the studies are very old and they have not been replicated recently. Then upregulation of sphingosine 1-phosphate, which is a protecting enzyme, and then protecting a possible germinative stem cell. But again, this is all theoretical. What we actually added to that is that GnRH agonist will protect those follicles that are bigger and that produce AMH, allowing continuous production of the AMH by these larger follicles. And so they would decrease this follicle burnout of the primordial follicles undergoing that first step of development that we were discussing before. And so that could be another step to prevent, for which GnRH prevent ovarian reservoir decrease. So we also found, we also did a study to really find out whether the GnRH analogs were really protecting the ovarian function. And we found that in all studies where the GnRH analogs were given, like in this case, goserelin and triptorelin, these are very similar to Lupron, but they are longer acting, and so they require typically fewer injections. And you can see that by looking at the dots to the right of the line, you can see that there is a positive effect. These are forest plots, and anything to the right of the line measuring 1 would signify a positive effect. Instead, everything to the left would signify a negative effect. So you can see that in all the studies, this was actually a positive effect as protective on the ovaries. And so following all the studies that came out on the positive effect of GnRH analogs, also the ASCO decided that it was, the ASCO is the American Society of Clinical Oncology, basically decided that the GnRH analogs should be added to our repertoire of ways to prevent ovarian damage during chemotherapy. However, unfortunately, that has been limited to breast cancer. And there's also another limiting factor, which is that they should never be used in place of other proven fertility preservation methods. So let's go over and see what are these two proven fertility preservation. The first one is the oocyte cryopreservation, or embryo cryopreservation also. And what we do with that is we stimulate the ovaries for 10 to 12 days, so that instead of having that one follicle that typically is developed and ovulated with one menstrual cycle, we will have many more. So we will stimulate many more follicles to grow, as it can be seen in this ultrasound image. And when the size deems that the egg inside is mature, we will go to a oocyte retrieval, which is done under ultrasound guidance. And then we can perform the oocyte vitrification. This is, which is a more high-tech form of oocyte freezing. With this technique, we can stop there, and then we can eventually fertilize those eggs with the sperm of this patient's partner whenever she's cancer-free and she's ready to start a family. Alternatively, we can also create embryos directly by fertilizing the egg. And then we can freeze the embryos instead. And that can happen, of course, if the patient already has a partner and she's ready to have a family as soon as she's cancer-free. But how many eggs are necessary to be frozen to basically assure that this patient will have a pregnancy in the future? Well, studies that were done early on in the 2000s showed that it depends on the patient's age, how many eggs we need to actually set aside for the future. Because as you can see here in this slide, about 5% of eggs are chromosomally abnormal in a woman that is 22 years old. But when the woman becomes 41 years old, we know that 65% of those eggs are actually chromosomally abnormal. And that is because of what we were discussing previously, of the finite number of oocytes that age with the woman. So in another study by Goldman, it was basically studied with the number of eggs that were retrieved, what was the chance of pregnancy, and basically we saw that if we have 20 oocytes and the woman is 34 years old or younger, she has 90% chances of getting pregnant out of those 20 oocytes. And so that is very comforting, and it gives us an idea on how to counsel the patients undergoing cancer treatment. And if we can sometimes squeeze in an extra egg retrieval, if we have only 5 eggs, for instance, from the first one, that's always to the benefit of the patient. The ovarian tissue cryopreservation is the youngest technique, as I was saying before, and that entails harvesting the cortex of the ovary, which is where all the oocytes and follicles are stored. Nowadays, we don't take portions of the ovary any longer. We actually take one whole ovary, and then we prepare the tissue in very thin strips, and we freeze it still under liquid nitrogen. And then whenever the patient is cancer-free, we go ahead and transplant that tissue back to the patient's ovary. That is the ideal location, but other locations can be found still within the pelvis. So the tissue cryopreservation has proven effective because it has given many pregnancies throughout the years. And with this study from 2019, which is out of Leuven in Belgium, this was basically a cumulative study of all patients from 5 centers in Europe, and they found that the pregnancy rate was 29%, which compared to a natural conception, which is about 25% per cycle, this was actually a very good outcome for these cancer patients. So as a summary, the options that we have at the Cleveland Clinic are the 3 of them. Of course, we have the GnRH analogs that we can offer, but we can also offer oocyte cryopreservation and ovarian tissue preservation. And we want to always work with the oncology team taking care of the patient to decide which one of these forms of fertility preservation is the best that can be actualized for the patient. And we also have a coordinator, and her name is Shoshana. This is her cell phone number. You can reach her directly if you have any questions for any of your patients. And you can also place an order in Epic, and Shoshana will be the one answering those requests as well. So I thank you so much, and I'm open for questions as soon as Dr. Vij is done. Thank you.
Thank you, Dr. Detti, for the wonderful talk. We will leave the questions till the end. At this point, we're going to move to Dr. Vij's talk. She is going she's going to go over the options for fertility preservation among men.
I'm a urologist at the Cleveland Clinic, and the focus of my practice is on male infertility. So I'm going to sort of talk about the male side, whereas Dr. Detti covered the female side, and they are pretty different, but we do certainly have some overlap. All right, so I'm going to talk about the male side, about fertility preservation. I'm also going to talk about sexual health in survivorship patients with colorectal cancer. Right, so just some background. Fertility on the male side can be affected by treatments for colon cancer. And so a discussion about fertility preservation for male patients is critical. And the process is relatively straightforward in men, certainly a little bit simpler than it is in women. And the key is to complete this process prior to starting therapy. So it's really sort of on us as providers to make sure that this service is offered, and important for patients to hear about it. And then sexual health can be impacted by colorectal cancer and its treatments. And in fact, sexual health is often a bigger issue for colorectal cancer survivors than fertility, because the agents used in colorectal cancer generally are not as gonatotoxic as some other malignancies. So I will touch on that a little bit today. And for survivors, it's important to refer to a sexual health provider and make sure that that's part of the survivorship program, because it's often overlooked just sort of due to its sensitive nature. So spermatogenesis is a highly complex process that occurs in the level of the testis. So I have a cross section here, the male reproductive system, and you can see the testis. Sperm are made there. It's a 72-day process. The onset begins at puberty, and sperm are continuously being made in adult men. So very different as compared to the female. Sperm are, again, continuously being made, and because they are rapidly dividing, they are impacted by chemotherapy and radiation agents. So as I mentioned, it's a very highly specialized process that takes a diploid cell and turns it into a very highly specialized haploid cell. And you can see here, this is a cross section of a seminiferous tubule, which is the tubules in which spermatogenesis occur inside the testis. And at sort of the periphery of the tubule, you have sperm precursors, basically stem cells that are going to progress and divide into mature sperm, which are then released into the lumen of the seminiferous tubule, and all of the tubules will send their sperm out towards a structure that's called the reedy testis, and then into the epididymis. And sperm that are sitting in the epididymis are the sperm that are released when a man ejaculates. So this process to initiate and sort of turn on spermatogenesis, again, occurs at puberty, and it's a hormonally initiated process. GnRH, gonadotropin releasing hormone, is secreted from the hypothalamus in the brain in a pulsatile fashion, and that stimulates FSH and LH, which are hormones made by the pituitary, to essentially tell the testis to turn on, start making sperm, and start making testosterone. And a single cycle of spermatogenesis, to go again from a stem cell to a mature sperm, is about 72 days, and it's a continuously ongoing process. So when we look at a patient, pre-treatment, and we want to determine what is the impact that that treatment regimen might have, it's important to have some understanding of their baseline fertility. Do they have other risk factors for infertility? And again, that's sort of my job to tease that out. Things like undescended testicle as a child, any other prior surgeries, use of testosterone, several other things. So are there any concerns just about their baseline fertility? And then their age at the time of treatment, when they're going to be receiving treatment. That's really more relevant if it's a sort of a peripubertal patient population, which is a little less relevant for this audience. The type of cancer, very important, and the treatments they're going to be receiving. So the regimen, the dosing, the duration, and this is where I really rely on my colleagues in medical oncology, radiation oncology, and colorectal surgery in this case, to determine, what this patient might need, therefore how gonatotoxic or toxic to the testes might this regimen be. And then again, any other independent risk factors for male infertility. And independent of all of these things, it really is recommended that all male patients, if able, cryopreserve sperm. So these are guidelines from our sort of overriding fertility society. And the key here really is that if the patient is eligible for fertility preservation methods, and then again, the most commonly utilized one is semen cryopreservation by masturbation to collect and ejaculate, then they should bank. Again, independent of sort of how potentially toxic the therapy is going to be, because not everybody has the exact same response to treatment. And there's also been data to suggest that banking sperm can help men cope emotionally with the cancer diagnosis. It's I think helpful for patients to be forward thinking about their future, helps them think beyond the treatment and potentially to cure and survivorship. And it can help just sort of with their emotional state as they go through something that's incredibly scary. So options for fertility preservation on the male side, again, a little bit simpler than on the female side. So sperm banking is really the biggest one. And as long as the patient can provide an ejaculate, they can bank. And it'd be pretty unlikely in this scenario for a patient to have no sperm in the ejaculate if they don't have some other significant urologic history. So again, if they bank prior to treatment, as long as they can provide an ejaculate, the service can be offered. Unfortunately, insurance companies do not cover this completely, so there is a financial burden sometimes for patients and families, and sometimes that's really our only barrier. Now we're working towards this at several levels. We have some Velasano funding for adolescent patients, sperm banking, and young adults, and we're constantly working with the Cleveland Clinic essentially to try to allow for some of these costs to be covered for patients who can't afford it, because obviously this is incredibly important. And then after sperm banking, we do talk about testicular shielding. So patients that are undergoing radiation therapy, the testes are shielded during treatment to decrease the scatter that reaches the testes during treatment. And then testicular sperm extraction is a surgical procedure that we perform in patients typically in the survivorship setting when they have not had return of sperm to the ejaculate. So if they did happen to receive a very toxic regimen, it's really shut down spermatogenesis completely. And again, this is not as common in the colon cancer patient population, but we can sometimes still retrieve sperm by going into the testis and finding little islands of intact sperm production. And then the other setting that we'll do a testicular sperm extraction is if for some reason the patient is unable to provide an ejaculate. And we do see this sometimes in our patients who are really, really profoundly sick. They're unable to provide a specimen, but really their testes should be functioning adequately, and we're able to bank directly from the testis. And then electroejaculation and penile vibratory stimulation are essentially taking advantage of a reflex arc in men that can be stimulated with either a vibratory stimulator or with an electrode that's actually placed in the rectum. It has to be done under anesthesia to cause an ejaculate. That is most commonly done in our spinal cord patient population, not so common here, although I suppose the two diagnoses could overlap. But that's really the whole sort of list of fertility preservation options in men. So sperm banking. So again, I mentioned patient must be able to provide an ejaculate, and a lot of our patients will ask, well, how long is my sperm going to be good for? You know, if you have a patient who's 22 years old at the time of their cancer diagnosis, maybe they're at least 10, 15, 20 years away from fatherhood, is that sample still good? And the answer is yes. There is data that you can use bank sperm to create a pregnancy really for years and years. So certainly that should not be a reason to not bank. And then options for using banked sperm, and Dr. Detti touched on pieces of this, but unfortunately with bank sperm, you can't have a natural pregnancy. So we do have to take advantage of our artificial reproductive techniques to be able to use the sperm to actually have a baby. And there's really two main options. One is IUI, or intrauterine insemination, where the sample would be thawed and spun down to collect the good motile sperm and then placed into the female uterus with a small catheter. It's essentially like a pap smear for a woman. And then in order to do an IUI, you do have to have a fair amount of sperm banked, because you need to inseminate around 5 to 10 million sperm to create a pregnancy with IUI. So the more sperm the patient banks, the sort of more options they have for reproduction. And then most commonly in this situation, patients are undergoing IVF, or the form of IVF in vitro fertilization that we typically do here is called ICSI, or intracytoplasmic sperm injection, where an individual sperm is injected into an individual egg, grown in the lab for 5 or so days into an embryo and placed back into the uterus of a female to cause a pregnancy. And for IVF ICSI, you really only need a very few sperm. So usually a single banked sample in a patient who's otherwise, reasonably healthy is sufficient. So I'm going to switch gears a little. I know we're a little bit short on time. I'll just go over sexual function in male cancer survivors, because again, I think this is really important and often not addressed for various reasons. But all the treatment options, particularly for colon cancer, surgical, radiation, chemotherapy, not so much in this case endocrine, that's more common in some other malignancies, but can impact sexual function. And there's really several effects on the male side. So erectile dysfunction, we do see that, loss of libido or sex drive, interest in sex, ejaculatory abnormalities we can see in men who have undergone pelvic surgery. Anorgasmia, meaning the patient is unable to have an orgasm or reach climax. And then concerns just about cosmesis, patients with stomas, et cetera, sometimes can impact their sort of confidence and sexual function, and as it relates to body image, and just the psychological impact can in turn cause loss of libido and erectile dysfunction. So we certainly see this in our cancer survivors. And sexual dysfunction actually is one of the most common long-term effects of colon cancer treatment, and it's not often addressed. And there's a lot of reasons for this, and certainly we can do better as providers, and patients are often sort of hesitant to bring this up. And so it's really our job to ensure that they're doing okay sort of in this realm. And the key is really to address their concerns throughout illness, and then just make sure that patients are referred in a timely manner to a specialist. So that's really all I had. I just have my email on here. I'm happy to take any questions if that's next in line.
Okay. Thank you so much, Dr. Vish. For the interest of time, we're going to leave the questions till the end. I want to encourage participants to please type their questions. We'll go over those at the end, or we will reply individually in the chat box. Next speaker is Dr. Karen Hurly. She is our clinical psychologist. She has over 20 years of experience. She is interested in, and she has cared actually for patients with inherited cancer syndromes throughout her career. She will giving us a talk now, and she will go over strategies and tools to cope and manage life detours. Go ahead, Dr. Curry, the stage is yours.
Okay, thank you so much. I really appreciate the kind introduction, and it has been my privilege to work with the WISE team for over 4 years now. So we're going to be shifting gears quite a bit out of the research lab and even out of the medical office into taking these research findings, these advanced technologies, and bringing it back into your life. What I'll be presenting today comes in part from research on psychosocial issues for people who have experienced cancer, and also from my experience of sitting in the therapy room with many, many people who have struggled with these issues. Just to note, I don't have any conflicts of interest, and any photos that you see, because I have some illustrations in there, don't depict any actual patients. So cancer has this unnerving, startling way of putting up a big stop sign in what's going on with your life, depending on if you're in a hereditary cancerous family, maybe you've been dreading cancer for a long time, or maybe it has come completely out of the blue. And one of the things that happens, your life is going this way, cancer comes this way, and then winds up knocking you off track in some way. So there may be some life goals that you are working on that are now thwarted or out of reach. There may be goals that you have to delay, right? That you have to take a pause for treatment, and that pause might be, a year, 2 years, as you're going through treatment and starting to feel better. Or sometimes you'll still be able to achieve your goals, but they'll still be altered. We just heard some very good examples of that with all of the different possibilities for fertility preservation. And still being able to conceive after cancer treatment. But truth be told, no one grows up thinking, oh, I want to do in vitro fertilization someday, right? So the alteration of the goal of having a family from natural conception to
using some kind of assisted technology is a pretty significant alteration. So if cancer is the red light in the road of life, what is this road that we're on, right? And so the road that we're on is the road that we are all on, and these are how we develop psychologically as our bodies mature from infancy all the way through to old age. When we are first born, you know, we learn to trust, and we learn to experience care through being cared for as infants, moving on to the explorations of a toddler, learning to accomplish in the school years. And the kinds of cancers that we've been talking about today tend to hit in these two middle sections: the exploration of identity. Who am I? Who do I want to be? And then as you start to build that identity and the details fill in, turning that into a life, building it, building family, education, career, lifestyle, right? So these, so right at the point of the beginning of turning goals into life experience and life accomplishment is where we experience that thwarting and that interruption. So that's one of the reasons that we focus on people with young onset cancers, because it does intersect differently for people who are older, people who've already been through these earlier stages and are more about creating what their legacy, you know, what is their contribution to life, and being able to look back on their accomplishments. Cancer still has a strong impact, but the questions for self are different. Now, another thing that happens in cancer, and in colorectal cancer in particular, is that we can feel as if we get not just thwarted or stopped, but get knocked backwards, at least for a little while. You know, the last time that anybody was as interested in your poop as your surgeon or your oncologist is now was, you know, around 2 or 3, right? So it can feel as if you're going backwards. It can feel as if you've lost some of your independence. Because if you think about it, one of the various early markers of our sense of being independent is being able to control our poop, right? And that's what lets us move around in the world and go different places. So what do we do when we've experienced this disruption, right? How do we navigate this? So first of all, we want to start with noticing what is changing, right? So we want to be able to you know, start to name, okay, what can you do? What can't you do? What's easy? What's hard? How is your body changing? What does that mean for your goals? Or what you are afraid that means for your goals. And then this is the tough one, is that sometimes certain things are going to become out of reach. For example, natural conception. Maybe that's not going to be possible anymore. We know from research that people who persist in goals that are no longer attainable experience multiple frustrations and become at risk for depression over time. So there's a certain point where it becomes important to acknowledge which ones are no longer possible as is, and to acknowledge them as a loss. So, you know, we know what it's like to lose a person, right? That, you know, you may have been, you know, experience a loss of a loved one, loss of a pet, loss of a, you know, something that you had really wanted. And then, you know, that grief can be very overpowering for a time. Our futures have an existence that also have that same quality. We can experience the loss of a future we had imagined, and it can feel as real as losing a person. So here I am talking about loss, right? And, but it's the more common narrative in cancer is that, we've got to stay positive. You have to keep fighting. You want to, keep pushing through your goals. Nobody can tell me what I can't do, right? So, being positive is important. Looking forward is important, but there's a certain point at which it can either set you up for frustration, right? Or that it can invalidate some of the other feelings you're having. So if someone tells you, well, you can't do this, you can't do it this way anymore, but you can still, it invalidates that period of grieving that needs to happen before you can figure out what you're going to be doing instead. So what happens next is you start to, just as someone who's grieving tends to need some time alone, right, to process what's happening. And there's a period that one writer calls the neutral zone of what we might call inattentive activity, right, or attentive inactivity, where you're allowing yourself to spend time in meditation, just hanging out, staring at the window, journaling, allowing the release of things that are no longer possible and clearing out a blank space so that what is going to be possible can emerge, right? We have to clear that out first time. And very importantly, when you're a cancer survivor, there are certain times when you are, alone or inactive due to not feeling well. This does not count as that creating space-time. This comes after you start feeling better. So this is why, for example, people who are in treatment will sometimes feel like they, at the end of treatment, and then start feeling sad or having different feelings. And people say, well, what's wrong? You're done with treatment. It's because you're going into that neutral space. You're sort of finding out, what were those emotions that got kind of put to the side while you were focused on just getting through the treatment. So then the process of resuming the path, out of that space that you've created, it comes from a series of psychological adjustments. And different people will emphasize one or the others, but these are all important components of resuming your life path. Reprioritizing, figuring out what is important to you now. You'll probably hear stories about people who say, well, after going through treatment, I realized how important family is, or how important relationship is, or how that a particular part of their self-expression needs to come to the fore. Recalibrating, figuring out what's your measure of a good day. A good day needs to always be within reach. So for example, if you're having a lot of fatigue now, you may not be able to do what you used to do. So you have to readjust and recalibrate your goals from day to day, so that you can then have, so that a sense of accomplishment is still possible. Being able to shift your focus from what you can't do, which might feel like a lot after treatment, to what you can still do, right? And that's where that sense of possibility opens back up, and being able to define, who are you now, given all that you've been through. So to wrap up, if we talked earlier about the toddler as that very earliest experience, the very early experience of exploration. This is the energy that we can tap into to re-enter the world by exploring, how is your body now? What's changed? What has not changed? What is possible for you? The only way to find that out is to be back out there and try it out. See how your relationships have changed. Maybe some people have drifted away, but some other people are closer. And these reckonings are what help you adjust your goals so that they are once again within reach, so that you can have a sense of fulfillment to be possible. And again, we've all been here, right? This is our natural birthright, right? To have this sense of exploration. We're driven to get up on our feet and move around, right? Re-engagement, being able to move back out into the world, that's the norm. Being resilient is what most people are able to do after treatment. We can't promise when or how that's going to come about, but that is where people, that's where I, as a clinician, put my trust in people's natural resilience that comes out of this core drive that we have for exploration and engagement. So we as a team are here to support you, and you can support each other in finding your individual path out into the world of living and living well with your cancer survivorship. So thank you very much.
Thank you, Dr. Hurly. Now we're gonna move to our third talk. And I'm very pleased and honored to introduce Dr. Carol Burke. She is a senior gastroenterologist with many years of experience. She has been on national committees, written colorectal cancer screening and surveillance guidelines. Her load of research had contributed to much of what we know now, especially when it comes to cancer prevention and inherited cancer syndromes. Her talk today will target colonoscopy, surveillance colonoscopy, and screening for family members. Dr. Burke.
Thank you, Carol. It's an honor to participate with you all today, and really over the last 30 years, when Carol said senior gastroenterologist, Dr. Macaron really meant to say the old gastroenterologist.
Not really. I'm very proud that you were my mentor for so many years. So thank you for coming today.
Thank you. Okay, so my task today is to talk about surveillance colonoscopies and screening of relatives. Some of what you're going to learn over the next few slides here have been are redundant. You've heard about them earlier, but I think some of the key facts are really important. Is that colon and rectal cancer is common and preventable. And we know very strong data suggests that screening for colorectal cancer decreases colorectal cancer. So if you are having colorectal cancer screening, early stage preventable colorectal cancer can be detected, right? Curable. And if you detect colorectal cancer early, you decrease death from colorectal cancer. If colonoscopy is used and polyps are detected and removed, we know that that could decrease colorectal cancer incidence. So really important concepts. And Dr. Schmit earlier today showed you the American Cancer Society numbers of estimated colorectal cancers and associated deaths. This slide again shows you that both in American men and women combined, that colorectal cancer is the second leading cause of colorectal cancer and death. This is another slide that shows that age is important. So if you take a look at individuals under the age of 50, you can see both in men and women, the risk is much less than 0.5%. And when you get to roughly the age of 70 to 79, the cumulative lifetime risk is almost maxed out. So 3% in men, ages 70 to 79, about 2.9% in women. And overall, from birth to death, our risk of colorectal cancer, both in men and women, is about 4%. And that's taking all comers. You've also seen the part of the slide below that shows the incidence of both colon and rectal cancer. So on the bottom left, in individuals that are over the age of 50, you can see since about 1985, the rates of colorectal cancer have decreased, as well as the colon cancer have decreased, as well as the rates of rectal cancer. And if you take a look at the bottom here, and these are age-adjusted incidence rates per 100,000 people in the United States, you can see that individuals under the age of 50 are kind of percolating along, and you can't really see very much, but much lower incidence than older patients if you look at the axis on the slide. However, move over to the right here, and when you take a look more closely at individuals under the age of 50, again, the axis of the scale is much different than over here, where we're looking at rates of starting at 150,000 for colon cancer, and over the last 30 years, decreasing to about 80 per 100,000. In young people, you can see that the rates of both colon and rectal cancer are increasing, which you've heard earlier. And when did this start to occur? Roughly in the early 90s. So what's the disparity here? Individuals over the age of 50 have been undergoing colorectal cancer screening since roughly the 1980s. And so the associated decrease in those age groups over time, whereas we haven't suggested screening in individuals that are younger than the age of 50, and with what's ever happening in our environment and lifestyle, the increased risk. So what are the predisposing factors for colorectal cancer? You've heard those today. It's cigarette smoking, alcohol intake, excess body weight, independent of physical inactivity, consumption of red and processed meats and processed foods, and low consumption of fruit, vegetables, dietary fiber, and dietary calcium. And when I see patients in the office, I ask them 3 simple questions. And the answer is, if it's 0, then your answer is 0 to 1. How many fresh fruits do you eat every single day? How many measuring cups of vegetables do you eat? Rice, lettuce, and potatoes aren't included. And how many servings of grains do you eat each day? And I'm stunned. Dr. Cresci actually gave some information that may be published, but in my office, people are rarely getting 5 to 10 grams of fiber per day. Another risk, so those are controllable things. Another thing that you can't control for is chronic inflammation in the colon. And we know that chronic inflammation, no matter where it is in the body, whether it's in your lungs from smoking, whether it's in your cervix from HPV, or whether it's in your colon from inflammatory bowel disease, Crohn's colitis, or ulcerative colitis, that it is the fuel to change the genetics and lead to cancer in the colon. And then there's other things that you can't change. Your ethnicity, African-American race, aging phenomena, personal history of getting polyps or cancer, family history of polyps or cancer, and then certainly things that Brandie has talked about with the hereditary colorectal cancer syndromes. So what are some key definitions regarding colorectal cancer risk and reasons for colonoscopy? When you take asymptomatic individuals that don't have particular risk factors for colorectal cancer, they're considered average risk. You can have individuals that have a moderate or higher than average risk of cancer. So that would be individuals that have a personal or family history of polyps or colorectal cancer, the patients that have chronic inflammation in their colon, and those individuals with hereditary colorectal cancer syndromes. And the risk elevates as you go through those 3 different characteristics that I've laid out. I'm getting a lot of calls from patients when I do colonoscopy to say, hey, Dr. Burke coded something wrong on my colonoscopy because my insurance company is not paying. I would encourage you all to look at your insurance policy, because I don't do any coding. All I do is state the reason why you're having the examination. And the indication for colonoscopy can be screening, and that's what we apply to average risk individuals, or it can be surveillance, and that's individuals that have an increased risk of colon polyps or cancer. It can also be called high risk screening. And as been mentioned before, a diagnostic colonoscopy, the indication would be rectal bleeding, change in bowel habits, or weight loss. So those are some of the indications for colonoscopy, and your insurance company may not pay for one of those exams versus the other one. So really check what your insurance pays for. I don't do the coding. I just write down the reason why I'm doing the exam. Lynch syndrome, FAP, personal history of polyps, personal history of cancer, something like that. Okay, what is the impact of family history of polyps or colorectal cancer on colorectal cancer risk? Excuse me 1 second. the basic tenets are the more relatives you have, the higher the risk. The younger age of relative at diagnosis of polyps or cancer, the greater the risk. And if you have a hereditary cancer syndrome, certainly the lifetime risk of colorectal cancer can be as high as 50 to 100%. If you take a look at the graph on the right side of the slide here, this is a recent study that looked at the impact of having colorectal polyps in a first-degree relative on your risk of colorectal cancer. And what you can see here is that individuals that don't have a first-degree relative with polyps have the lowest risk over the next 10 years of getting colorectal cancer. Who are the individuals at the highest risk? You can see with the dotted line up here is individuals that had at least one first-degree relative with polyps under the age of 50. And this also pertains to colorectal cancer, but this is new data that shows that polyps, and in fact, any type of polyps in a first-degree relative increases your first-degree relative's risk of colorectal cancer. So it used to only be colon cancer was a concern for first-degree relatives. Now it's also that colorectal polyps and all colorectal polyps. So what are the colorectal polyps? The histology, their appearance under the microscope are either adenomas, including tubular, tubulovillous, or villous adenomas, or the serrated lesions. They look like a sawtooth under the microscope, and those are hyperplastic polyps, sessile serrated polyps, and traditional serrated adenomas. 70% of colorectal cancers that develop in individuals in the United States arise from adenomas, and that's also the precursor for the Lynch syndrome-related colorectal cancers. And these serrated lesions, in particular the sessile serrated polyp, also known as the sessile serrated adenoma or the sessile serrated lesion now, account for about 30% of colorectal cancers in the United States. The genetic ways in which they turn into cancer are slightly different. So these are some images of adenomas. On the left side of the slide here, you can see at the base of the colon, this is where the appendix would have come out of the colon, and this is an adenoma. And you can see in this other slide, another adenoma that's quite big and has some features of indentation or ulceration, which is very concerning. How often are adenomas found? Well, if you're having a screening colonoscopy, in the best of hands, doctors that are high detectors, carefully looking, and you've cleaned your colon out, they're detected in about 45 to 60% of average risk individuals. What about these sessile serrated polyps? You can see that they look much different than the adenoma. They're very subtle, can be hard to detect, and they're often the cause for interval cancers, cancers that develop after your doctor said, oh, colonoscopy looked XYZ, come back in 5 years or 10 years, and then all of a sudden in 3 years, you've developed a colon cancer. So these are the lesions that traditionally are the cause of, interval cancers, we believe. You can see how subtle in the upper left, this very flat polyp is only picked up by that subtle rim of debris. And you can imagine if there was a stool that's coating the colon that you couldn't even see that. On the upper right here, you can see that this just looks like a little lumpy, bumpy place on a fold. So it looks like a cloud, often covered with a glob of mucus, so important for your doctor to clear that off. On the bottom left here, you can see very subtle lacy blood vessels, but can you imagine how easily this flat lesion that looks exactly the same color as the surrounding lining could be easily missed if someone isn't being very diligent and looking? But these very lacy blood vessels are a tip-off. And then on the bottom right, you can see another blood vessel feature that we look for, which includes these blood vessels that come in and stop abruptly around this lesion, completely flat, easy to miss. Okay, you've already heard this today too, but the new update from the United States Preventative Services Task Force is that individuals begin colorectal cancer screening at the ages of 45. And so we can't say you're 50 and over, we can relax you, because we know that rates of colorectal cancer screening in individuals 50 to 55 are going down, and rates of colorectal cancer are going up in them because they're not having their screening. But now we need to encourage individuals having colorectal cancer screening at the age of 45. And the impact of screening on young people isn't known yet, but as Dr. Schmit said, the modeling studies would suggest that we can prolong life longer than if you detected a colorectal cancer in a person that's the age of, 85 or 90, and all the other impacts that have been talked about, difficult impacts on family and life and planning, as Dr. Hurly has gotten to, when young onset colorectal cancer is detected. And this is for average risk individuals. They suggest that if you've gotten to the age of 76 and have had screening and you don't have anything, you could be done if you don't have any other risk factors. And you should individualize colon cancer screening at that age based on how long you think that your patient is going to live, the other factors that we've talked about that may enhance increased risk of colorectal cancer. But this is the new update on the U.S. Preventative Services Task Force. So what options are available for average risk individuals? These include stool tests that are done on a yearly basis, the old stool cards that looked for an enzyme reaction with, blood in the colon that can be present in the stool, but it also picks up the enzyme in certain fruits, vegetables, and can pick up the blood from poorly cooked meats. The new kid on the block that really has superseded guaiac-based testing is fecal immunochemical testing. There is a genetic fecal immunochemical test, so detecting blood as well as some genetic markers called FitDNA that's recommended every 1 to 3 years. Certainly colonoscopy every 10 years. And then there's a variety of other things that are less commonly used, including CAT scanning, which has radiation risk, flexible sigmoidoscopy, which is just a short scope, or flexible sigmoidoscopy coupled with every year fecal immunochemical test, which is better than the guaiac-based test because the fecal immunochemical test actually tests for an antibody to human breakdown of blood, human globin. Okay, let's get into family history here. It is recommended by the U.S. Multi-Society Task Force on Colon Cancer that individuals that have a first-degree relative with colon or rectal cancer or an advanced polyp that in a first-degree relative that's under the age of 60, or in 2 first-degree relatives or more at any age, you begin your colorectal cancer screening at the age of 40, and it should be with a colonoscopy every 5 years. The break point is the age of the first-degree relative. And so individuals that have colorectal cancer or an advanced polyp in a first-degree relative that's the age of 60 or over also begin at the age of 40. However, their risk is lower, so it's suggested that any of the screening tools that we have available could be used. The important thing to consider is that if individuals that have an older relative at the time of diagnosis of cancer or polyp have no significant polyps or neoplasms, as they're also called, by the age of 60, you can, so 20 years of screening, you can consider expanding the interval between colonoscopies. A lot of our patients that are listening have polyps. So this is not patients with hereditary colon cancer syndromes, but there are new recommendations for the frequency of colonoscopy in individuals that have colorectal polyps. So based on the size, the number, and the type of polyps under the microscope is how frequent these exams should be done. So there's information that helps guide your doctors on how frequently your colonoscopy should be done based on polyps. So what about individuals that have had colorectal cancer? This again is information from the U.S. Multi-Society Task Force on Colon Cancer. And generally, you should have your first colonoscopy after curative colorectal cancer surgery within 1 year. If that's normal, it's repeated every 3 years. And if it continues to be normal, you don't go at an interval less frequently than 5 years. And it could be shorter if polyps were detected on the examination. Rectal cancer is a different story, and oftentimes the colorectal surgeon prefer to do at least a sigmoid examination on a more frequent basis to look at the area where the rectal cancer was, but suffice it to say, the full colonoscopy is done on that interval. it's important that individuals that have had a cancer that obstructs the colon, so the colonoscopy can't go through prior to surgery, that they should have the examination shortly after healing from surgery to ensure there's no other lesions that need to be addressed. What about the hereditary colorectal cancer syndromes? Completely different ball of wax from individuals that got a sporadic colorectal cancer. And so generally the concept is that colonoscopy begins early and is much more frequent than every 10 years or every 3 to 5 years. So in Lynch syndrome, it begins around the ages of 20 to 25, or 2 to 5 years earlier if the young individual was 20 years old when they had their colorectal cancer, and it's done every 1 to 2 years. In FAP, it begins around ages 10 to 15 and is done on a yearly basis. The cousin to FAP, the MYH-associated polyposis, begins no later than age 25 because it generally affects individuals a little bit older in age than at FAP, and it's done every 1 to 2 years. And for the hamartomatous polyposis syndromes, Peutz-Jeghers syndrome, juvenile polyposis syndrome, generally colonoscopy begins in the mid to late teens and is done every 2 to 3 years. With Cowden syndrome, the P10 hamartoma tumor syndrome, it generally begins at the age of 35 and done every 5 years. And for individuals with hereditary mixed polyposis syndrome due to a GREM1, they begin at an age depending on the family history. So suffice it to say, these are broad strokes, but in individual families, depending on the age of cancer, it may be a little bit earlier. And if things are found on the examinations in these patients on colonoscopy, instead of saying a blanket statement of 2 to 3 years, it may be done a little bit sooner based on the size and number of polyps that are detected. And then lastly, in the hereditary cancer syndromes, we can't forget that other organs are at risk. So these are systemic diseases. You know, every cell in the body is affected with a change in the genetic material. So we need to keep our heightened risk on other organs. And if your doctors are not paying attention to other organs that are at risk, let us know. We can provide documentation or remind them that hereditary cancer syndromes involve much more than just the colon and the rectum. Thank you for your time, and I'm happy to take questions at the end of the session.
Thank you, Dr. Burke. We're going to move to our last but not least talk for this session. I'm very happy and pleased to introduce Dr. Todorov, who is a family medicine physician with a specific interest in lifestyle medicine. She is going to give us her input and her thoughts on lifestyle medicine in patients who had cancer.
So, and I know that, thank you so much for inviting me to talk about the importance of lifestyle changes and discuss the correlation between nutrition, physical activity, and risk of cancer and cancer recurrence. I'm the medical director for Center of Integrative and Lifestyle Medicine. And at the end, I'll share what resources we have if you want help navigation through your journey in lifestyle changes. First, I just wanted to show you that there is a lot of research, and it was mentioned by the previous speaker that there is a correlation between diet, physical activity, and body weight and risk of cancer recurrence and mortality with cancer. And also many interventional studies shows that when people make the change, they do feel better, they do experience less fatigue, and they do decrease the risk of cancer recurrence. With this, I want to share with you that current recommendations for cancer prevention that are coming from the World Cancer Research Fund and American Institute for Cancer Research is pretty much summarizing all the lifestyle changes that are associated with lower risk for cancer and lower risk for recurrence. And I will spend like a minute in each one of these circles. So first, being a healthy weight, be physically active, and what they do recommend is 30 minutes of moderate or high level of physical activity a day, plus twice a week doing strength exercise.
The next couple of points are about diet. Eating a diet rich in whole grains, vegetables, fruits, and beans. Eating diet that is less or doesn't consist of fast food and other processed food high in fat, starches, or sugar. Also limit consumption of red and processed meat, and limit consumption of sweet drinks. Limit consumption of alcohol, no smoking. Also, there is no study that shows that any supplements can decrease the cancer or prevent cancer. And also breastfeeding, it's another one that decrease overall risk of cancer. So the first one on the circle was be at a healthy weight. If you do not know your weight, look at, we provided any discharge summary. You can Google online and calculate my body weight. It's a body mass index and it's calculated based on weight and height. The normal is 20 to 25. Overweight 25 to 30, more than 30 obese. So if you are in higher than 25, we can help with lifestyle modifications to start moving toward the healthy weight. Again, this study came in 2019 showing association between obesity and increased risk of early onset colorectal cancer, specifically in women. With that, I'm moving to the second lifestyle change that's important for cancer prevention and survivorship, and that's physical activity. This specific study that was published in 2011 was meta-analysis. What does it mean? You put all the studies that look at the correlation as much as possible between exercise and mortality. It doesn't matter from what reason. And they included more than 1.2 million patients. And what it shows that people who do exercise 150 minutes a week, which is around 30 minutes, 5 days a week, have 14% relative mortality reduction. So I always tell patients, if I give you a pill that will decrease your risk of dying by 14%, would you take it? And yes, there is some side effects of muscle pain, tiredness or something like that after the exercise, but would you take it? So that's the exercise. If you do exercise 300 minutes a week, which is around an hour, 5 days a week, that is correlated with 26% of reduction of mortality. And as you saw that they use the word moderate or vigorous intensity exercise, and here I put a couple of examples. But shortly think of, if you're doing vigorous exercise, you will not be able to talk in a full sentence. If you're just walking and talking with somebody, that is probably a light exercise. Here the recommendations are by American Diabetic Association. Of 150 minutes per week of high level of exercise, or if it's intensive, 90 minutes per week. Independent of exercise and obesity, prolonged sedentary TV viewing time. So think of screen time, watching at the TV, at the computer, is also associated with young-onset colorectal cancer, particularly of the cancer of the rectum. So I urge you, try for a week, calculate how much is your screen time and try to increase it. Because even if you do exercise 30 minutes or 60 minutes a day, think of what are you doing in the rest of the 23 or 23 and a half hours. With that, I'm moving to diet. As you can see, there was like 4 different points on the diet, and this slide pretty much shows 2 different studies showing that the poor diet is associated with high risk of early onset distal and rectal adenomas of high malignant potential. And on the other side, they researched 3 different diets that shows that the more you follow the diet, the less association of colorectal cancer in men you have. And the 3 diets that they looked are, it's fancy names, but dietary approach to stop hypertension, alternative Mediterranean diet, and alternative healthy eating index. And I put for you what these diets encourage and discourage, but what is in common between them is eating more fruits and vegetables, eating more whole grains, brown rice instead of white rice, or anything made from white flour, quinoa, whole grain products, rye, a lot of legumes, beans, lentil, garbanzo beans, and healthy fats like nuts, seeds, olive oil, fish. And the three groups that are discouraged is ultra-processed food, sugar, red, and processed meat. Specifically, this study is showing the correlation between fruits and vegetables. It was mentioned earlier, and if you look the statistics, there is 40% of people eating less than one vegetable a day, 20% of people eating less than one fruit a day. So this study again looked at 18 different countries, and people who are eating more total amount of fruits, vegetables, and legumes have lower mortality rate. Doesn't matter if it's heart, non-heart related, or total mortality. And kind of the breaking point, the most benefit you get is from 3 to 4 servings total of fruits, vegetables, and beans. So how you get there? Eat a lot of vegetables, salads, soups. Make sure that half of your plate is full with vegetables. Snack on, hummus with different kind of vegetables. When you think of sandwiches, don't always think of ham and cheese. You can always put a lot of vegetables there. Fruits has benefits by itself. Don't forget that saying that an apple a day keep a doctor away. And in the first study, they asked people to eat 2 apples a day and measure their microbiome before, 1 week after that, and 2 weeks after that, and they noticed change of the good bad bacteria even on day 7. Also, in a different study, they looked at people who are eating like half a pound of vegetables a day, and that was correlated with 13% risk of diabetes. Kiwi fruits, like 2 different studies, eating 2 kiwis a day helped you with constipation. Beans, again, beans are a very high fiber food, high protein food. When I think of protein, plant protein, I always think of beans as the first choice. Healthy fats, fish, olive oil, extra virgin, cold press, avocado, nuts by itself have extra benefit. Again, there is another meta-analysis here that you can look. Eating a handful of nuts a day is correlated with 18% decrease of cancer. And think of like raw nuts, you can easily grab it together with the fruit. It's a healthy snack, no need for preparation. And with this, I'm switching to what are the things we want to avoid, to limit. And the first one in my list is anything that's considered ultra processed food. Again, that's eye-opening study 2019. Look at people for 20 years, around 20,000 people. They check what they eat in a questionnaire, and people who are eating more than 4 servings of ultra-processed food a day for over these 20 years were independently associated with 62% increase of all-cause mortality. And again, eating more increase your risk. In a different study, if you increase only with 10% the ultra-processed food a day in your diet, that is correlated with 10% increase in the overall cancer. And here is example of what does it mean, ultra-processed food. So always think of, when you look at the label, anything that has more than 5 ingredients, anything that you cannot read or you cannot pronounce, it's an ultra-processed food. The second thing on the list, first is ultra-processed food. The second is sugar, added sugar intake. I would go by the American Heart Association recommendation. Try to limit to less than 6 tablespoons of sugar a day for women, and less than 9 spoons for men. And again, where is most of the sugar we'll find? It's in American diet, that is in the drinks. So be aware, read labels. I mean, think, for example, mocha frappuccino, you can get like 11 teaspoons, which is double of what is your daily recommendations. Sugar can have like multiple names, so in only one label you can find it under different names. So I give you a list of different names, so be a detective, read labels. And that doesn't include, when we talk limit the sugar, that doesn't include natural sugar that's coming in beans, in whole grains, in fruits and vegetables. And the third one, other than the ultra-processed food, sugar, is processed meat and red meat. Again, World Health Organization, look at their website, they came with a statement in 2015 that showing that eating processed meat is cancerogenic to humans and causes colorectal cancer. And every 50 grams portion a day increase the risk of colorectal cancer by 18%. How we cook it does matter. So barbecuing, pan frying, high temperature causes more risk for cancer versus boiling and baking decrease the risk. And here is the definition of a processed meat and some examples. So again, to kind of summarize on the healthy eating habits, first eat more fruits and vegetables, legumes, whole grains, healthy fats. And what you want to limit is the ultra processed food. Again, anything that comes in a package, anything that has more than 5 ingredients, sugar, red and processed meat. In addition, try to exercise on a daily basis. And many times people ask, how often should I exercise? And the answer is only on the days when you eat. So be at a healthy weight, know your weight and where you want to go, stop smoking, avoid or limit alcohol consumption. And when you make a change, when you're trying to go through a lifestyle change, make an action plan. And that action plan should be specific, measurable, achievable, realistic, and time-based. For example, if you say like, I'll lose 50 pounds in 3 weeks or 5 weeks, that is the end goal. But you want to make a plan of something that you can control. For example, I can control, I can walk 30 minutes, 5 days a week, or I can eat 2 fruits, or I can eat a handful of nuts and a fruit a day. And that is specific, measurable, achievable, and realistic. And we do have a lot of group classes for weight management. We provide consults for integrative and lifestyle medicine physician. Our consults are an hour long, and we go through all your risk factors and make a very concrete, specific plan. We have yoga, virtual classes, meditation, all free, a lot of cooking classes that are free on our website. Here is the phone number to make an appointment. You don't need a referral, and all the visits are covered by major insurance. And thank you so much.
Thank you, Dr. Todorov. We do have a few questions that I would like to go over. Few things to clarify. A patient is asking whether diet sodas fall in the category of sugar sweetened drinks. And the other question that I think we should answer is protein products, like what is the best protein to go to? And is there any dietary recommendations for patients who have ileostomies, who cannot consume much of those raw vegetables and insoluble fibers that leads to increased stoma output?
Thank you. These are all great questions. So I'll start with the soda. So diet soda is a ultra-processed food. So if you look at the labels, can you pronounce anything there? So to me, the diet soda is not better than other soda. And also think of when you drink diet soda, your brain is expecting sugar. If you don't get sugar, you end up eating more of the other foods around. So it's no. The second one is the protein. If you look at the plant-based protein, again, going back to the beans, lentil, garbanzo beans, and soy edamame, 1 cup of beans have around 12 to 16 grams of protein. When you compare to, for example, 1 egg has 6 grams of protein. Chicken has almost, 20, 22, so the same as the beans. And we can talk a lot about beans. If you cannot tolerate them, you can increase slowly, so your body can try to process them, and we can work with that with you on that one. And the last one is about the stoma and vegetables. So steaming vegetable makes it easier to process. So that's one way to go. And also there is so much variety, and we can start with what you can tolerate, and we can kind of spoon feed and increase the amount. But again, steaming, cooking, it's the way to go. Great questions.
Thank you. I wish my kids were listening to this talk to reinforce the messages that I say every day. Now, we do have some questions to Dr. Burke, but before I go over the patient's questions, patients who had cancer, patients who have inherited syndrome, their only options for surveillance is a colonoscopy, and they often need that very frequently. They're under the enhanced surveillance program. So how safe are these colonoscopies, and what are the risks that the patients are subjected to when they undergo such a test?
Thank you, Dr. Macaron. I have had questions in the last year or so that I've never had in 30 years. And some patients feel like the more colonoscopies they have, the weaker their colon becomes, or the more risk they have. And I would say that if you are being cared for by an expert who's careful and the bowel prep is good, the risk of having colonoscopies every year, and I know sometimes for some of you it's been 30 years, is no greater than your first colonoscopy. And the risk is not cumulative, but there is always a risk of perforation, bleeding, infection. And the major risk of a serious perforation or bleeding is less than 1 in 2,000 patients. So that's a really important concept, and I was surprised when someone asked me that. However, where might be a greater risk? As people get older, it's been shown in some data sets that older individuals are at greater risk of colonoscopy, which might include perforation or bleeding, oftentimes because they have coexistent diseases of diverticulosis, which could weaken the colon wall a little bit. They're on blood thinners, which if you stop them and you really need them, you could have, a stroke. And then bowel preparations are not innocuous, right? So people get dehydrated, and some of the components within a bowel prep can affect the kidney. So electrolyte alterations that could affect the heart. So I just think diligent colonoscopists that are, caring for patients need to look at their whole. So I think that was the question about colonoscopy and risk. Carol, was there something else I missed?
No, that was it. That's perfect. Now, a really interesting question asked by the patient today is, what are we doing to encourage doctors across the country to take young adults' GI issues seriously and not like that you're too young mindset? And I know you're on national committees, you're on meetings a lot, and what's been done now to increase that awareness among patients, but also physicians?
Right. So, the first step is, knowledge is power. So patients need to empower themselves. And in terms of me as a gastroenterologist, in collaboration with our primary care providers, and on all of the recent guidelines and communications and information that's being put out by the National Colon Cancer Roundtable, is colon cancer is increasing in young people. Do not dismiss rectal bleeding as a particular heinous symptom that could be colorectal cancer. So, we're spreading the word at a national level involving patient organizations, primary care organizations. So I think the word is getting out there, but knowledge of this and patients need to be diligent and to just continue to push the message. And if you've talked to your primary care provider and they haven't said, oh, you need a colonoscopy, then you need to contact us at the Weiss Center or your gastroenterologist, and we can help push the issue. And not only in young people, but the other thing is individuals that we care for in their families that have hereditary colorectal cancer. And my Lynch patients will say, oh, my son went to his doctor who said, oh, you don't need to have a colonoscopy because of XYZ. Well, if you have a hereditary predisposition to cancer, then you do need to have colonoscopies, and we can provide letters to our patients who can provide them to their family members if needed to say, here's what needs to be done.
Exactly. There was one question about MYH, a children of a parent with MAP whose second parent was negative. When should they start their first colonoscopy?
Thank you for the question. MAP is one of the autosomal recessive syndromes. So most of the hereditary colorectal cancer syndromes are inherited in a dominant fashion. This one is recessive, and that's why the important point, this patient said, maybe I'm positive, but the mom, my spouse, the mom of the kid is negative. So children will have a risk of inheriting one of these abnormal pathogenic variant is what it's called. So if you're just a carrier of a single MUT-YH pathogenic variants, there isn't very strong data that suggests that your risk of colorectal cancer is increased. There's some data that suggests that maybe, if 4% is the average, risk in the population, it may be 1.5-fold increase, so maybe 6%. And so the National Colon Cancer Network has looked at the data and provided guidance that says, if you have a single MYH gene and your first-degree relative, your parent had colorectal cancer, you need to begin at the age of, and I wrote things down because there's differences here, at the age of 40 and have your colonoscopy every 5 years, unless the colorectal cancer was younger in your first-degree relative, and then you back it up 10 years, like we've talked about. If you have a single MYH pathogenic variant and you have a second-degree relative with colorectal cancer, it's not known that your risk is really higher. So, there is no strong guidance. And then if you have a single MYH mutation and your parent who has the polyposis has never had cancer, again, there's no strong data or starting ages. So I think it all depends on individual situations, but that's the guidance that's available for providers and patients.
Okay. Thank you so much. I know we're 10 minutes behind. I'm going to leave it to Dr. Liska at this point, and we'll conclude.
Thanks, Carol. One more question I would like to get to that was asked earlier, both for Dr. Vij and Dr. Detti. It was a question that a patient asked whose husband was diagnosed with FAP when he was 12 or 13. And at this point, they're trying to figure out how they're going to have children. So I guess for Dr. Vij first is, what's the best way to go about for a man who had multiple surgeries as a child in terms of fertility and how to get that worked up? And then the second part of the question was, how can you avoid passing on the disease to a fetus? And, Brandie answered about some pre-implantation genetic testing, and I wonder if Dr. Detti can talk about that. So Dr. Vij, if you're still on, in terms of for a male who had many surgeries, in terms of what's the best way of starting a workup to figure out if you can have children? I don't know if Dr. Vij is still on, so maybe Dr. Detti, if you take the second part.
Oh, sure, Dr. Liska. Actually, the first step would be to perform a semen analysis and see what the semen quality is at this point. And in regards to the second part, the pre-implantation genetic testing is possible. And so typically what we do if we don't know the location of the gene, we usually probe the paternal gene first, and then we look for that same gene in the embryo. The way we do it is that after fertilization, we culture the embryos up to day 5 or 6 of development, and then we extract a small number of cells and we analyze those. Typically is 5 to 7 cells that we extract, and we just analyze for the presence of that same gene. If the gene, of course, is present, we label that embryo as affected, and of course that possibly would not be transferred.
Perfect. Thank you so much. So yeah, thank you all for your questions. Thank you everybody for attending. And I really want to thank the fabulous faculty for all the time you spent and these really excellent presentations. And like I said, these presentations will be uploaded to our websites down the road. We'll try to package them by topic so that patients have the opportunity to look them up. In terms of our websites, you can always call the Y Center to talk to one of our coordinators, and thanks to them. They're here in the background. Margaret, Lisa, Susan, and Lakeisha also. Thank you so much all of you for everything that you've done. And here, yeah, thanks, Steve. These are the websites where you can find us, emails to email us. And like I said, we'll be posting these on our websites, these talks down the road, so anybody can access them. Also, if any questions come up or any other feedback about the event today and what you want to hear at the next event, if you like the virtual format or in-person format or a hybrid, we're open to any suggestions. So again, thank you all very much for attending, and thank you to the fabulous faculty. Thanks, everyone.